normal, and you get these kind of bizarre structures. So this is the property of light on any other wave. Ultrasound also follows the same. Let us say if you have an object here, the ultrasound beam hits this object, goes back, it looks as a nice object. But many times if this wave comes through a kind of a refractory lens and it is deflected on one side, like you saw the spoon being deflected, then the wave would go back from this and it would appear as if there's another structure lying close to the previous one. And that's an example. You see a nice aorta and a faint aorta on the side. This is because of refraction from the pericardium, which has happened in the front. Interesting artifact, which we've seen plenty of times, is mirroring. You put two parallel mirrors and they would have an infinite images right across. So if you have a transducer, you have a strong reflector like a pericardium, it would reflect and produce a reverberations. And similarly, if there are two reflectors placed parallel to each other, it will produce multiple refractions. And these multiple refractions or reverberations are called the tail effect. I'll show you example of both. Now, this is an example of a mitral valve and on a transesophageal echo, and you can see a faint mitral valve by a dashed shadow, and you can see another mitral valve in the lower panel, and this is parasternal, and you can see another mitral valve, but this is just a simple reverberation and nothing. But it's not limited to 2D. It is there for color Doppler as well. Look at two jets of mitral stenosis. So there is no jet going through the commissure, don't worry. This is again an artifact, but if you change the views, you'll be able to remove this artifact. This artifact you have seen in plenty. The moment you see an arch from suprasternal view, you see another aorta lying behind the descending aorta, and that is a mirroring artifact and should be acknowledged accordingly. Comet tail artifacts, as I told you, are two mirrors lying parallel to each other, very in close proximity. There is a metallic tissues lying in close proximity to each other, would produce a comet tail sign behind in the prosthetic valve. And this is a patient with a post-myocardial infarction, calcification in the endocardium, and it's producing a same kind of comet tail sign. The mirrors are this pericardium and this calcification. In a fetal heart, we see echogenic foci, which is very, very common. This is nothing pathological, just a calcification of the head of the papillary muscle, resolved by itself. But many a times when you put a color Doppler, you see again a comet color sign on a color Doppler or ringing sign. Interesting case. Now, this is an aortic stenosis. You see vena contracta here, elasing right beyond that. But if you do a CW, you get a gradient, a nice high gradient. But you see these spiky things in the Doppler spectrum. Now, this is because of the valve which is hitting the Doppler and producing this loud noise. Till that, it was fine. We did a parasternal long axis view and we put the color Doppler. We don't know what is happening here. We really do not know whether there is a jet, whether it's an MR, TR, what is happening. Really, we do not know, because now this is a high wall filter and I reduce the wall filter to low fall. The artifact still there, but at least I could make some head and tail. Why filters did make this change, I do not still know. When I come to know, I'll let you know. But if you put a pulse Doppler, even in the middle of aorta, you get aortic stenosis signal. LA wall, you get an aortic signal. LA mid, you get an aortic signal. It's dispersed all across. Many people call this as a Doppler thrill. You know, you can see on an M mode the color filling in the LA also. This is a near field collector. You can see this collector because of the increased ultrasound waves in the proximal segment and the reflection from the ultrasound probe. And this produces these noise here and can mask a thrombus or look like as a thrombus. And the side lobe effect is, I don't want to go into physics. I have a very limited time. Now, this is a side lobe. You know, this is the true structure, which is pericardium. And this is the false structure, which is a side lobe projection of this into this. This is basic anomaly of an ultrasound technique in itself. And this is not quadratum, this is just an artifact. So similarly, you can have an artifact which can mimic a dissection of aorta. I reviewed this patient from other views. There was no dissection. This was produced by some structure either in front of the plane or behind this ultrasound plane and produced this kind of a side lobe. One last case which I want to show you and wind up. This is the patient with a large VSD with an amal-aligned septum and overriding of an aorta. And you see this is a dilated pulmonary artery, and you see a structure in the pulmonary artery. We made a diagnosis of dissection. This wasn't present in all the views, but surgeon really surprised us that I looked everywhere around after surgery and there was no dissection. So this was an artifact. So this artifact is, I wind up by last slide, this artifact is the most critical and important. If you get these kind of electromagnetic signals or signals like this, which is there, you better watch. There could be a breach in the lead, or there could be a breach in the transducer, or there is a problem with earthing, which is equally unsafe, or it could be simple large magnetic field around your premises. So I thank you all for patient listening and asking me to do a Shri Ganesh of the conference. And fact about the artifact is that shadows may look different from reality. Thank you very much.
Thank you, Dr. Singh.
Thank you, Dr. Singh. A fantastic presentation as usual. He's always lucid and very poetic to listen. I did not receive any questions on chat so far. Hansa, do you have anything on your part?
No, nothing. It has been wonderfully shown. So is the audience there to ask any question? We are open for the question, or else we move on for the second talk. Okay, I think we move on to the second talk, and in case the questions come, we'll take it later on. Okay, we'll save on time that way.
Dr. Singh, once again, it's a pleasure to hear you. Every time I hear, I learn something how to present. Thank you for a wonderful inauguration of IAE.
Thank you, sir. Thank you very much.
So our next speaker is ready, Dr. Jesu Krupa from CMC Vellore. Dr. Jesu will be, he'll be the second speaker. Please go ahead, Dr. Jesu Krupa. He'll be talking on quantification of MR, AR with special reference to Vena Contracta, its limitations and solutions.
Thank you, chairpersons, and thank you for having me to share this particular topic. I'll go straight away to the case. So this is a 54-year-old female with dyspnea exertion for 1 year. And what we see here is a dilated left atrium in the parasternal long axis view. There's quite a bit of MR, but we are not really seeing the details, as in measuring vena contracta and all will not really be possible in this particular view. What do we see here? We see the short axis view, and yes, so we see A1 to A3 segments from lateral to medial, P1 to P3 from lateral to medial. And what is right in the middle, as has been shown, is the prolapsed large PML. And that is what we are seeing here also. We see the large prolapse PML, and this is the parasternal long axis view, which kind of cuts through the A2 and the P2 segment, and that is what has been shown here. How do we quantify it? The PISA method has been demonstrated here, and what you can see is a very large PISA radius, radius of over 1 centimeter, and you are able to see the entire jet in this particular view, which we could not see in the parasternal long axis view. And here you are seeing the 3 components of the jet. That is, you are seeing the PISA head, you are seeing the neck, that is the vena contracta, and you are seeing the tail, which is the part of the jet. Also, we are noticing that the E velocity is very high. It's over 1.2 meters per second. It's around 1.6 meters per second. You are seeing a holosystolic MR, and it's a triangular jet that we are seeing, all pointing towards a very severe and significant mitral regurgitation. How do we do this PISA? We take a zoom view of the mitral valve. We lower the baseline as has been shown here, and we measure the PISA radius as has been demonstrated here. And then that PISA radius is the radius of that hemispheric shell. 2 pi r square times the mitral VTI, 2 pi r square times the aliasing velocity gives us the flow rate, and that divided by the peak velocity of the mitral regurgitant jet gives us the EROA that has been shown here. EROA is 0.78, and this times the mitral VTI gives us the mitral regurgitant volume, that is 74 ml, all pointing to a severe mitral regurgitation. This is the 2017 guidelines. And what we can see here is the ones that have been highlighted have the maximum impact or things that we should be looking for very closely. So in this particular case also, we saw a P2 which is prolapsed. That is a significant obvious lesion. It is there throughout systole. It's a triangular jet that we are seeing. We are seeing a large vena contracta. We haven't seen flow reversals, but we are seeing a dominant E wave. And of course, by quantification, a large EROA greater than 0.4 and regurgitant volume also greater than 60 ml. So all these things point towards a significant and severe mitral regurgitation. Vena contracta, how did we measure it? We took a zoom view of the mitral valve. In this particular case, we could not see it in the plaques as has been recommended. Why do we recommend it generally in the plaques? That's because of the axial resolution. Ultrasound beam comes this way, and if there's a structure which is perpendicular to it, then we are able to get the maximum axial resolution. So in this particular case, we can notice that the jet is going almost perpendicular to the ultrasound beam, and that is the reason why the vena contracta is best measured in this particular view for this particular case. So what is vena contracta? It is the narrowest central flow region of a jet that occurs downstream to the orifice. So if this is the anatomic orifice through which the leak is happening, the vena contracta is downstream the jet, and because of flow contraction, it is a little narrower than the anatomic regurgitant orifice. So as has been shown here, this is the parasternal long axis view, which shows the flow convergence area. Below that, you see the vena contracta, and beyond that is the jet. Often our eyes will look only at the jet and then we make assessments, but that is incorrect. We should be looking at this proximal part of the jet, which is the area of the flow convergence and the vena contracta, to make all our assessments on how severe the regurgitation is. So like in this particular case where you had a P2 prolapse, P1 being lateral and P3 being medial, you saw a fairly kind of circular kind of regurgitant orifice, so that if you took the vena contracta from multiple views, they would roughly be the same. But that is not the case in each and every case. There are conditions, especially secondary MR, where this will not hold true. So we saw that in the plaques, we could not measure it properly, but when the ultrasound beam is perpendicular to the jet, we are able to see it clearly and measure it properly. So we may need to angulate the probe in such a way that we are able to see the jet and delineate the jet very clearly. The next is a 13-year-old female with heart failure. Again, you can see the vena contracta and the entire jet, the flow convergence, the vena contracta and the jet. Everything is seen nicely in all views. Preferably take zoom views so that you can see it clearly. But what is interesting here, what I was referring to, is that it's not the same in all the views. When you go to a biplane or a two-chamber view, what you are seeing is that the jet is much broader. So that means that it is not a symmetric shape of the jet. The jet is not circular. So it is something like this. The jet is happening all along the coaptation line. It's not only in one area, either here or here or here, but it is all along. That is what this tells us. And hence, vena contracta in one plane may not be accurate. We need to do a biplane. That is the reason why in the guidelines also you have a biplane measurement for vena contracta. This is to show how we can go wrong in the measurement of vena contracta. So for instance here, you've seen that the scale has been brought down. That itself is an error. It's not been zoomed properly. You need to zoom it so that this whole thing fits properly. So you need a much bigger image to measure the vena contracta. Now, as much as it has on the jet, but nevertheless, we should ideally measure it between 50 to 70 centimeters per second Nyquist limit. Here again, we see some amount of mitral regurgitation. What is the severity is the question. These are all obvious examples. So again, you see here that the jet is happening, the regurgitation is only in the early part of systole. The rest of systole, there is no regurgitation. The same has been demonstrated here by color M mode. You see some amount of regurgitation here, later there is no regurgitation. And the importance of the A wave in the mitral inflow Doppler to show that this is mild mitral regurgitation. So the A wave dominance is seen here, and that tells us that it is mild. So the point to note here is that if the MR is not holosystolic, then single frame measurements like vena contracta or the PISA radius or the jet area, all these will be inaccurate because they will tell us how much regurgitation is happening in that particular frame. Whereas for the rest of systole, this is not accounting the regurgitation. So here in this particular case, we saw chambers are not dilated. We saw A wave is dominant, and hence this is mild mitral regurgitation. This is what I was telling about zooming properly so that this whole PISA radii fills the whole zoom sector and not such a tiny thing as has been shown here. And how the EROA can get corrected, or rather that we can get a better reflection of the severity would be in this case by regurgitant volume. So if we were to trace it, we have to trace this only this particular regurgitant jet, not extrapolate and make the whole thing like that. So that would give us an erroneous value for regurgitant volume. Whereas if we trace only the part that is regurgitating, that would be more accurate. This again is a case of secondary MR, again, just to highlight the fact that it may appear narrow in one particular view, but when you, like say, take the short axis view, you can see that regurgitation is happening all along the coaptation line. So this is a very broad jet, so hence biplane views, or rather 2-chamber and 4-chamber view may be necessary. Also to highlight the importance of taking color M mode, here we can see that the vena contracta is also dynamic. What is in the beginning is not what is in the middle of systole. And this is something which is seen quite often with functional MRs. So again, to note that one single value of vena contracta in one frame will not give us all the information. We need a collection of data to tell us what is what. This is a gentleman who was incidentally found to have a murmur. Again, straight away, it's a P2 segment prolapse that has been shown here, an anteriorly directed jet. And in the traditional plaques view, you are seeing a prolapse P2. Quantification was done as was done in the previous case that I showed, PISA radius and the ERO and regurgitant volume. ERO is very high. Regurgitant volume is also quite high, more than 60 ml. Again, a triangular jet. Again, a mitral E velocity greater than 1.2, all pointing towards a severe mitral regurgitation. Now, another way of kind of cross-checking this can be using the volumetric method. So we have taken an LVOT VTI and a LVOT stroke volume. How do we do that? Is by LVOT diameter, and that we get the LVOT area, and that times the LVOT VTI gives us the LVOT stroke volume. And we do the same for the mitral valve. The difference between the two gives us the regurgitant volume. So for instance, here we have LVOT stroke volume of 59 ml. We have a mitral stroke volume of 159 ml, a regurgitant volume of 100 ml. And what we had calculated by PISA was 90 ml. So a very large regurgitant volume. This patient was asymptomatic, chambers were not so dilated, EF was normal, strain was normal, there was no pH. This again to show the importance of delineating the jet properly. This is esophageal echo. What you can see again is the flow convergence. Our eyes should go to the flow convergence first, then to the vena contracta, and then finally to the jet, in that order. Whereas if we get enamored only by the jet, then we can get lost and we can make false assumptions. So what we see here is a flail P2 and a large jet. But what is even more impressive is the large PISA with a normal Nyquist limit of 50 to 70 and a large vena contracta also. This is a patient with a typical history of HCM, young patient. Again, you can see SAM, and because of that, there is a friction lesion on the mitral valve and the interventricular septum. You are seeing a turbulent flow across the LVOT, and you are also simultaneously seeing a posteriorly directed mitral regurgitation jet, which is happening at almost the same time as the SAM and the LVOT flow. So now what is the severity here? Here again, we see that it is mitral A wave is dominant, and the LVOT gradient is very high, telling us that it is severe SAM, severe LVOT obstruction. Most likely this patient, the MR also will improve if we take care of the SAM and the LVOT obstruction. However, there may be situations where the MR may be out of proportion, or not just that, it may be anteriorly directed, or there may be structural abnormality of the mitral valve, in which case we need to do a TE to make sure that there is no organic MR associated with the HOCM. The point here in this particular case with severe mitral stenosis is this, that is sometimes you can miss the severity of mitral regurgitation. It may not be clinically relevant here since the patient has significant mitral stenosis. But what enables us to tell that there is significant mitral regurgitation, as has been shown in this particular panel, is the fact that there is flow convergence which is happening in a certain view. That tells us that this is not mild mitral regurgitation. It could be just a problem with the views and our angulations, and we need to angulate and take proper views. The reason Dr. UP just shared just now, there can be reverberations and there can be attenuation at certain images. So for instance, here we see this part is all calcific. So anything distal to that is not going to be seen properly. So we need to angulate in such a way that we are able to catch the regurgitation. This is a problem.
Jesu, you have exceeded the time, please.
Okay, I'll conclude in just 2 minutes.
You have already exceeded your time.
Sure,
right? Try to conclude so that we stay within the time limits. Thank you.
Yes, ma'am. So I will go to my conclusion, which is that we need to go through the ASC 2017 guidelines, which give us a lot of information on these things. And we need to take proper views to get to the vena contracta and delineate the jet properly. And thank you all for your attention. If there are any questions, then maybe I could answer those.
I think we can take only one question, and that too at the end. Okay, Dr.
Sure.
Hansa. Dr. Hansa, I would because the time has been exceeded. I would love to go into the.
There's one question for Dr. UP Singh, but I think after this talk we'll take all the questions together.
Yeah. Now it's my privilege to introduce Dr. Sunil Bohra. Everybody knows him. He's a very widely known person. He's the Chief of Internal Medicine and Cardiology, Multi-Speciality Hospital, Bangalore. I will not waste further time. Dr. Bohra, the dais is yours.
To Dr. Ganguly and Dr. Hansa, and I thank IAE for giving me this opportunity to be with all of you this morning. My topic is on how to evaluate and interpret the left atrial appendage velocity. So we all know the left atrial appendage is a small pyramidal structure situated on the lateral aspect of the LA, extending between the pulmonary artery and the LV. So the complete structural and functional assessment of the LA appendage, it includes 2D and 3D imaging for the LA appendage size, its morphology, and to look at the contraction, and also to assess the LA appendage function quantitatively by the pulse wave Doppler of the LA appendage flow. So the primary indication for performing an assessment of the LA appendage is to rule out the presence of a thrombus. So echocardiographically, the LA appendage can be visualized by transthoracic echo by utilizing the parasonal short axis and the two-chamber view. However, transthoracic imaging is not recommended for complete assessment of the LA function. So for that, we need to do a transesophageal echo, and we can see the LA appendage very cleanly or very nicely by looking at the mid-esophageal views, the short axis view between 30 to 60 degrees, and the two-chamber view in between 80 to 100 degrees. And echocardiographically, we need to look at various aspects of the LA appendage while doing a transesophageal echo. We need to look at the contraction, how the LA appendage is contracting. We need to look at presence of SEC, which is a predisposing factor for thrombus formation. And moving ahead, we can obviously look at if there is any presence of thrombus, and in various parameters. And not to forget, we always have to look at the flow, the LA appendage flow by color Doppler. Notwithstanding, the 3D echo definitely helps, and it gives some incremental value in assessing the LA appendage morphology to look at its form, its shape, and then the presence of, we can look at the NFOS view and also look at the LA appendage very closely, define it very clearly, and definitely 3D echo has its incremental value. But then our topic today is more importantly on the assessment of the LA appendage function. So how do we assess the LA appendage function? So the left atrial appendage function evaluation has an incremental value in looking at the risk of clot formation, the presence of embolic events, and also to predict the success of cardioversion. So pulse wave Doppler measurement of the LA appendage flow velocities is the preferred method for assessment of the LA function. However, tissue velocity and strain imaging have also been evaluated in the recent past, though it is more of a research tool. So before we proceed to look at the velocity patterns, what are the imaging tips we need to follow? So we need to keep the sample volume placed at the proximal 1/3 of the LA appendage. The gain while recording the Doppler has to be kept low. Sweep speed preferably to be kept at 100 centimeters per second. And obviously, we need to avoid the artifacts by sampling the LA appendage wall per se. And pulse wave Doppler repeats a characteristic pattern depending on the underlying rhythm and the atrial function. So let's see what are the patterns. So in a patient who is in sinus rhythm, the typical description is of a quadriphasic flow pattern. So what is this quadriphasic flow pattern, what we see? So this is the animated image, and this is the original image of the pulse wave Doppler, wherein we have three waves which are being defined very clearly. The first one is the late diastolic emptying velocity, or the LA appendage contraction flow. Second one is the LA appendage filling velocity. Then we have the systolic reflection waves, and then the early diastolic emptying velocity. So let us look at each of these waves in detail. So we'll start with this early diastolic emptying velocity, which is the low velocity outpost signal, which is seen immediately after the mitral inflow. There is the E wave. The proposed mechanisms for this wave is a fall in the LA pressure following the opening of the mitral valve, and also due to the external compression of the LA appendage due to the distension of the LV. And the average value of this one is about 20 to 40 centimeters per second, and it correlates well with the mitral E wave and the pulmonary vein diastolic velocities. The second wave is the late diastolic emptying velocity, or the LA contraction flow. So this is the most important wave which is seen during the sinus rhythm and occurs immediately after the P wave of the ECG. So it is a result of the active LA contraction and is hence a marker of the LA contractile functions. We need to look at this wave very closely. And it correlates well with the LA ejection fraction, LA appendage ejection fraction. It correlates also with the LA size and the pressure, and is a significant predictor of thromboembolic risk. So we need to look at this wave very closely. And the average contraction velocity of this LA appendage contraction wave is 50 to 60 centimeters per second. So coming to the third waves, this is the negative wave which occurs immediately following the LA appendage contraction, and it is a result of the combined effects of the LA appendage relaxation and the elastic recoil. The average velocity of this filling wave is 40 to 50 centimeters per second, and it correlates well with the LA appendage contraction velocity. The next waves are called as the systolic reflection waves. These are low velocity, multiple alternate inflow and outflow waves, which follow the more prominent filling waves, and it's seen especially in patients with a slow heart rate. If there is tachycardia, we don't usually see them. And although the amplitude of these waves is correlating well with the LA appendage contraction and the filling waves, their functional significance is not very, very clear. And the other determinants, so these were the four waves. So what are the other determinants of these waves? So during tachycardia, the early and the late diastolic emptying waves usually merge and the reflection waves disappear. So we see only two waves, that is the contraction wave and then the filling wave. And other important is aging. So there is a decrease in the filling and the emptying velocity of about 2 to 4 centimeters per second for every 10-year increase in the age. And women tend to have lower emptying velocities as compared to men. So coming to the patients in atrial fibrillation. So in atrial fibrillation, the sawtooth waves of varying amplitude and regularity result from the active LA appendage contraction. And we can see this sawtooth wave pattern. And the velocity of these sawtooth waves is higher during the ventricular diastole and than the ventricular systole. And it this is because of the atrial contraction phase. And some studies have very clearly shown that a flow velocity of more than 31 centimeters per second is a predictor of the success of electrical or pharmacological cardioversion and also in maintenance of the sinus rhythm. So whenever you're doing this profile in patients who are posted for electrical or pharmacological cardioversion, you need to look at this so that you can give a fair indication of whether there will be success or not. In contrast to the atrial fibrillation, patients with atrial flutter, there is more regular sawtooth waves which we can see here, and they are more slower and are of higher velocity than the fibrillatory flow waves. Coming to the newer modalities, though we don't do it in actual clinical practice, tissue velocity of the LA appendage has been successfully used to quantify the LA appendage contractile dysfunction in patients with mitral stenosis, to track the effect of balloon mitral valvotomy, and to detect the impairment of LA appendage contractility in patients with hypertension and hypertrophic cardiomyopathy, even in the absence of atrial fibrillation. So how does the tissue velocity look like? So in tissue velocity, we usually take the left lateral ridge maximum velocity. So this velocity we need to look at during the recording, and this is how it is recorded in a sinus rhythm patient, and in patient with atrial fibrillation, we need to look at this maximum velocity. There are some studies wherein they analyzed and they found out that the LA appendage wall velocity of less than 8.7 centimeters was a predictor of stroke in patients with atrial fibrillation. And in another study, it was measured that the left atrial appendage, the left lateral ridge, if it was about 11 centimeters in sinus rhythm, and it was about 4 centimeters in patients with atrial fibrillation. So these are all having a very predictive values. So what is the left lateral ridge? So when we take a zoom view of this is the left lateral ridge wherein we measure the tissue velocity. And this is the basomedial appendage segment. So we need to look at these 3 points whenever we are looking at the tissue velocities. And there's one study when they did a correlation and they did strain imaging also, wherein they utilized 3D to clearly define the morphology of the left lateral ridge and the basomedial appendage segment in this region. And so studies with left atrial appendage strain imaging have shown a good correlation of various left atrial appendage strain parameters with the emptying and the filling velocities, as well as with the LA strain parameters. And this LA appendage strain imaging has also been shown to be helpful in quantifying the LA appendage contractile dysfunction, especially in patients with AF and in monitoring recovery following cardioversion. So this is how the strain imaging has been done. I'll not go into the details. It's just it is not the basic, so I'll just skip this. But I just put this image so that we can know how to do it. So they've done some strain image and looked at those 3 points which I showed in the previous slide. So I want to end this talk by summarizing that assessment of the left atrial appendage anatomy and function plays an important role in the diagnostic workup and management of many clinical conditions. And it is a mandatory investigation as a pre-procedure evaluation for patients who are undergoing BMB and other percutaneous closure devices to evaluate ischemic stroke, to look at the presence of thrombus or SEC, and it helps in prediction of thromboembolism and for the immediate and short-term outcome of cardioversion. So I'll leave with this slide. So we need to be very, very aware of these four velocities and evaluate it very carefully. Look at the imaging tips, that is though I've kept it at 66.67, it's better to keep it 100 centimeters per second, reduce the gain, look at the waves, and you can label it. And then especially important is to measure the velocity of the contraction and the filling waves. So I'll end here.
Yeah, thank you, Dr. Bohra. Dr. Ganguly, we have 3 questions. I think let's take up the questions to Dr. Bohra. So you please, tell him the 2 questions.
Yeah, Dr. Bohra, there are 2 questions. Both are from Dr. Vinayak, I think. Does specific morphology of left atrial appendage affect left atrial appendage emptying velocity and thrombus formation?
Yeah. So definitely the cauliflower shape of the left atrial appendage has found to be having more thrombus formation tendency than compared to the other morphologies. Definitely there are studies which have very, very clearly looked at this pattern. And definitely the shape of the appendage plays a significant role in predicting the thrombus formation.
Does it affect the LA emptying velocity also?
That I'm not sure. I've not gone through. I've gone through a lot of studies, but then I've not looked at this. But maybe we can look at it. I'm not aware of it. But definitely, it should to have a logical conclusion. It should definitely matter.
Dr. Vinayak, the other question is implications of low left atrial emptying velocity without any thrombus.
So it is a predictor of thrombus formation. So whenever the velocity is less than 30 or 31 to be more specific, the incidence of thrombus formation is very, very high. So lower the velocity, the incidence of thrombus formation is definitely high. That's why we do these studies, and to predict the thrombus formation and also to predict the success rate of cardioversion.
Thank you.
So again, here I would like to place one more important thing. So because of the LA appendage morphology and the shape, we tend to overdiagnose or also underdiagnose the presence of thrombus. So whenever the velocity is less, we need to look at very specifically at the presence of hidden thrombus, which is maybe very, very difficult, but then maybe 3D should help in these cases.
Thank you.
Thank you, Dr. Bohra. So moving on to the other next talk, I invite Dr. Rishikesh Shah, who is from Jupiter Hospital, Thane. He'll be talking on RWMA correlate with the vascular territory. Dr. Rishikesh.
Good morning, everybody. Thank you, chairpersons, and thank you, IAE, for giving me an opportunity to present this short talk. So my topic today would be regional wall motion abnormality correlate with vascular territory. So let's jump into the topic right away. So to look for the various regional wall motion abnormality in the LV, we need to assess the LV in the 6 planes, basically 3 long axis planes and 3 short axis planes. The 3 long axis planes typically are 4-chamber, 2-chamber, and 3-chamber view, while short axis at a level of the mitral wall, at the level of the papillary muscle, and at the level of the LV apex. Now let us start with the arteries. There are a left main coronary artery and the right coronary artery. The left main divides into LAD and circumflex. So LAD forms the most predominant artery of the LV, and it basically supplies around 60 to 65% of the heart. So let us go and assess the various territories from echocardiography point of view, which is supplied by LAD. So let's start with the 3-chamber. In 3-chamber, whole of this anterior septum, namely the basal, mid, apex, and the apical inferior wall, as well as the apical cap, whole of this is supplied by the LAD territory. In 2-chamber view, whole of the anterior wall, basal, mid, apex, apical anterior wall, as well as apical inferior wall and apical cap are again supplied by the LAD territory. While in 4-chamber view, the LV apical septum and apical anterolateral wall, or apical lateral wall for that matter, and apical cap are supplied by the LAD territory. So the LAD supplies the majority of whole of the anterior septum, whole of the anterior wall, and entire apex. So whole of the apex is supplied by the LAD territory. Now let's come to the RCA. The RCA basically supplies the RV, whole of the RV. Then it supplies basal and mid inferior septum. Now, commonly in 80% of the cases, the RC is the dominant circulation, whereby it gives rise to two branches, namely PDA, posterior descending artery, and PLV, posterior lateral vessel, which PDA usually supplies the mid and basal inferior wall, and PLV supplies the mid and basal infralateral wall or the posterior wall. So suppose if the RCA is predominant, RCA is the dominant circulation, then it will give rise to PDA and PLV. So the RCA supply would be the RV, mid and basal inferior septum, mid and basal inferior wall, and mid and basal infralateral or posterior wall. In circumflex territory basically gives rise to OM, obtuse marginal, and it supplies to mid and basal anterolateral wall over here. So if again, in 20% of cases, when the circumflex or left-sided circulation is dominant, the circumflex artery gives rise to PD and PLV. Then it will also supply the mid and basal anterolateral wall, mid and basal inferior wall, and mid and basal posterior wall or infralateral wall. So this is in general the circulation of and the various vascular territories which we'll look to assess. So we'll be talking of the regional wall motion abnormalities in terms of stress echo. So while evaluating, these are the rest images and these are the peak images. You need to go to each and every segment and look one segment at a time for evaluating the stress echo or for evaluating a regional wall motion abnormality. So you can use a stationary object like cursor and you see each and every segment so that you don't miss out on anything. Always go and assess, look at the endocardial border. Not just the endocardial border, the epicardial border also will help you. So look at the endocardial border and look for the endocardial border excursion. This will give us a fair good idea about the regional wall motion abnormality. Focus on wall thickening. This is one of the most important things, not just wall motion abnormality, but wall thickening. And the simplest thing what you can do is you can put your simple cursor there and just see that wall goes and touches it. So this is the simple thing which you can do to just see if the wall goes and touches that. If you cannot see two or more consecutive segments on an echo, on a plain echo, please make use of a contrast. You can see this contrast gives beautiful delineation of all endocardial segments. So whenever you can see, are not able to see more than two consecutive segments, use contrast for better endothelial delineation. And now improving appreciation of this thing. Now just watch. These are the two images. One is of full systole and one is of half systole. Here you can see the LV contractility looks fairly good. But here you see when you reduce it to a half systole, you see the apical septum is lagging and it is not taking off. Now this is most important point in differentiating or picking up certain regional wall motion abnormality quite early. So what basically it is, to overcome the translational or tethering motion, these are the various things you have to look for. Look for thickening of the wall, that's important. Watch first half of the systole. Translational or tethering motion occurs in the later part of the systole, while the true systole or the true thickening occurs in the first half of the systole. Look for anatomical landmarks to know you haven't migrated one out of the plane. So what are the pearls? What are the important things which you look for to look up for the sensitivity of reading of the regional wall motion abnormality? So first is look for thickening, not only motion. Look one segment at a time. Look for endocardial border and epicardial border. Look for LV cavity size at peak systole. Normally at peak systole, the LV cavity should normally shrink or reduce. Look for LV shape in systole, bumps on the triangle. Look for distalmost area of the perfusion. Remember this, wherever is the regional wall, usually the proximal also will give rise to the, so distalmost part of the territory supply is the first one to get affected. An isolated regional wall motion in isolated basal inferior wall or basal inferior septum are likely to be false positive. So you have to keep these things in mind. And now let us go ahead with the cases. So this is 39 years male, come with monomorphic VT, no ACS. So this we did is stress echo. These are the resting images. These are the peak images. You can see the peak, the LV cavity, which was bigger one, has narrow, has become a triangular, a shorter one. There is no regional wall whatsoever, and there is a good thickening of the endocardium. These are 4-chamber and 3-chamber view. Again, this is 4-chamber and 2-chamber view. You can see there is no regional wall motion abnormality whatsoever. LV is good. So there is treadmill stress echo, basically does not show any regional wall motion abnormality. His angio was later done at some other place and it turned out to be normal. Case 2, 32 years old male, impaired glucose tolerance, non-smoker, came with atypical chest pain. He had intermediate pretest probability. And this was his echo. These are his rest images. These are his peak images. You can see in the rest images, the apical septum and apical lateral wall are contracting so well. While at the peak, you see the apical septum and apical lateral wall has ballooned up and they are hypokinetic here. Same thing is here. In 3-chamber view, whole of the anterior septum you see in the rest is contracting so nice. And here, whole of the anterior septum has almost standstill. So what you can see basically is not only that, the LV cavity size is also increased. Okay. Let's go further. In 2-chamber view, you can see that whole of the anterior wall, LV mid and basal anterior wall, while mid and basal inferior wall are contracting normally. But LV apical inferior wall and apical anterior wall are not contracting or hypokinetic. So in this case, you have a regional wall in whole of the anterior septum, in whole of the LV apex. So this goes in LAD territory, regional wall motion abnormality. So let's see, and his angio showed a tight proximal LAD. Can you see that? Right. Let's go to the case 2. 49 years old marathon runner, non-diabetic hypertensive, had one episode of uneasiness during practice. His tropi was 0.006. His CT calcium score was 1095. This was his baseline ECG. And this was his echo. You can see in his echo at peak exercise, the inferior septum is quite lagging. Not only that, the inferior wall has become akinetic completely. If you can watch, mid and basal inferior wall, mid and basal inferior septum. While whole of the apex, the anterolateral wall, the anterior wall are contracting very hyperdynamically rather. These are the 3-chamber views. Here also you can clearly see at rest, the posterior wall is contracting very well. While here, the mid and basal posterior wall is almost not contracting. While whole of the septum, apex and apical lateral wall is contracting well. In short axis also, you can see on the lower border, you can see the infero-posterolateral wall, they are hypokinetic. While the upper one, the anterior septum, the anterior wall is contracting quite well. So here you see regional wall motion abnormality in inferior wall and posterior wall. So this is probably related to the RCA. So this is a tight RCA. The third case, 47 years old male, diabetic chest heaviness, had all stress test positive at high workload, tropi was 0.02, undergo stress echo. This was his rest ECG, this was his peak, and this is it. You can see here, basal mid and basal and mid anterolateral wall is a kind
Dr. Rishikesh, you need to conclude. Your time
yeah,
is
yeah,
up.
Yes, ma'am. Yeah. So this is again, this showed regional wall motion abnormality in circumflex territory. So this stress echo basically showed a circumflex lesion and his angio showed a tight circumflex lesion. Fine, I'll conclude here. Thank you.
Thank you so much. Thank you so much. It was very crisp, and I'm sure the younger generation will be very happy to, see these, multiple images and multiple cases. Dr. Ganguly, we have one question for Dr. UP Singh.
We have one question for Dr. UP Singh, and there is one question by Dr. Monica for our last speaker. What is meant by tardokinases and its significance?
Okay.
Dr. Shah, please.
Yeah, thank you. So basically, normally what happens in tardokinesia is this, there is no thickening happening. Normally in hypokinesia, you see that the wall excursion is less. In akinesia, there is no wall excursion at all. Okay. In tardokinesia, there is some amount of wall excursion, but there is practically no thickening. The thickening remains more or less the same. And that is very, very early sign of an ischemia. And that really happens with this. Now that 100% does not is a sign of ischemia. Even in some tethered segments, like if you have an akinesia of the nearby wall can also show a bit of tardokinesis. Okay, so that's not a very specific sign of this thing, but a subtle sign if you want to pick up subtle things in stress.
No, thank you so much. Dr. UP Singh, you have a question from Dr. Jadhav. How will you reduce artifacts? Dr. Singh, are you still there? Dr. Singh, are you still there?
I think if he's not answering, we need to move ahead because the next session is already about to start.
Yeah.
So thank you, everyone. Thank you, all the speakers. Wonderful session. Thank you all. And we move ahead with the next session. Thank you so much.
Thank you.
Thank you, IAE.
Thank you. Thank you all.
Dr. Hansa Gupta, you have to, thank you. Dr. Rajesh Nair, I don't see your other chairperson. This is Dr. Raghu from Hyderabad. But I see Dr. Jesu Mohan and he is ready. So I think we can get started.
Thank you, Dr. Raghu. Good afternoon, ladies and gentlemen. Talking about hepatic vein Doppler flow in health and disease. There are three hepatic veins, right, left, and middle. Middle and right are usually together, fused together near their insertion in about 2/3 of the cases, and hepatic veins are mirrored to the right heart. There are many variations of the hepatic veins. The cardiologists probably are not interested, but of course you need to know in case you want to go in details of the anatomy. In hepatic vein, in the middle cardiac vein, the pulse wave Doppler sample is placed about 1/2 to 1 centimeter proximal to its insertion with inferior vena cava. And with pulse wave Doppler, you would see 4 waves. Of course, the usual caveats for the pulse wave Doppler have to be followed. And the 2 retrograde waves are A wave and V wave. V wave sometimes it can also be isoelectric or could be at the baseline. And then there are 2 forward waves, the antegrade systolic wave and antegrade diastolic wave. The mechanism of these, it has to be understood that normally the S wave is a dominant and the flow is the systole dominated flow. But the mechanism of A wave is right atrial contraction. The center of annulus, the turn of annulus accounts for the V wave, and passive filling due to AV gradient accounts for diastolic wave. Sometimes you can see 5 waves. There is a C wave also as a result of, again, the tricuspid annulus motion, and it comes just after the A wave. But nevertheless, this is the relationship of these waves with the right ventricular pressure and with the ECG. So as I said, systolic wave is dominant and diastolic wave is less than that. And of course, there is some degree of the atrial reversal wave. Sometimes you can see C wave also. Keep in mind one thing, that these are velocities which are mostly in the range of 20 to 60 centimeters. They rarely exceed 100 centimeters per second. Hepatic vein flow Doppler depends upon right atrial properties. There can be abnormal relaxation, reduced compliance, and elevated filling pressures. And all of these will affect the hepatic vein flow. Hepatic vein S wave actually strongly negatively correlates with the mean right atrial pressure and can be used along with inferior vena cava in assessing the right atrial pressure. But there are other variates, or there are other denominators of hepatic vein S wave, and these are RV systolic function measured by TEPSE, degree of TR, and right atrial relaxation. So as I said, the data actually published by Sharif Negi about a quarter of century back suggested that hepatic vein S wave, whether you look at its VTI or S wave velocity per se, has a very strong negative correlation mean right atrial pressure. And if mean right atrial pressure more than 8 millimeter taken abnormal, then a systolic wave fraction of less than 0.55 correlates with the right atrial pressure more than 8 millimeter, with sensitivity and specificity which is close to 90%. So let me just show you an example of a 52-year lady with diabetes and possibly restrictive cardiomyopathy. We categorize this lady, the mean right atrial pressure 21 millimeter shown at the top. You see the hepatic vein flow, and you hardly see S wave. The S wave is shown here, very small compared to the D wave, and of course by Negi's equation, we estimated right atrial pressure to be 19 millimeter, which is similar to what we got by cardiac catheterization. So the S waves are markedly reduced whenever right atrial pressure gets elevated. Another example where, of course, you have an S wave which is much smaller than D wave, shown here in 27-year male with heart failure, and this indicates, of course, the inferior vena cava itself tells you that the right atrial pressure is significantly elevated. There is also a very prominent A wave, which actually again correlates with the right ventricle and diastolic pressure. So obviously patient has problems with the right ventricle diastolic pattern and with the right atrium. However, the right ventricle systolic function is the dominant determinant of S wave and not the mean right atrial pressure. In patients with constrictive pericarditis or cardiac tamponade, S wave fraction does not correlate with right atrial pressure. Here is an example of a 39-year male with constrictive pericarditis, and you would see the S waves as still dominant over the D wave, despite mean right atrial pressure being 25 millimeter of mercury. A similar example is shown here in a patient with cardiac tamponade. You can see large pericardial effusion in the left upper image, inferior vena cava which is markedly dilated and does not collapse with inspiration. And you see here again that there is systolic dominance. So here again, remember, in pericardial diseases, S wave does not correlate with the right atrial pressure. This is again a 9-year-old child with S wave dominant in heart failure. Obviously, the child has constrictive pericarditis. You can easily rule out restrictive cardiomyopathy by looking at the dominant S wave. But sometimes, of course, you can have exception. This is 37-year male with constrictive pericarditis, and you can see that the S wave, there is a reversal of the S wave, despite patient having constrictive pericarditis. We have shown you the R wave, the right ventricular diastolic pressure about 25 millimeter, right atrial pressure high. But what is the catch here? The catch is the right atrial relaxation or right atrial, the reservoir strain is grossly abnormal, and patients of constrictive pericarditis who have myopathic involvement of right atrium, right ventricle would have S wave very small or maybe reversed as in this case. So hepatic vein S wave may be normal in constrictive pericarditis despite increased mean right atrial pressure, because here all the three denominators of S wave are normal: RV function, TR, and RA relaxation. In tricuspid regurgitation, you have reduced a reverse S wave and accentuated A and V wave shown here. Hepatic A wave strongly correlates with right ventricular and diastolic pressure, and also, of course, shows variation with respiration. Constrictive pericarditis also it is dominant, and whenever patients have complete heart block, then A wave gets very prominent, especially when the right atrium contracts against the closed tricuspid valve, and in AF, A wave can be absent. So here is an example of very prominent A waves being shown in a patient who has markedly raised right ventricular end diastolic pressure. And as I said, same thing can happen in tricuspid stenosis and complete heart block also. Sometimes you will see interesting pattern. Here is a pattern with somebody who has congenitally absent tricuspid valve, and you see antegrade A wave. Normally A wave is retrograde, but antegrade A wave is a classic pattern which shows that RA and RV are behaving alike. You can also see this kind of pattern in Fontan, post-op Fontan cases. Sometimes you may have no A waves because of the atrial standstill or atrial fibrillation. However, A wave may be absent even in sinus rhythm despite P wave being present, and that is because there is no gradient between RA and hepatic vein during right atrial contraction, and hence the RV RA are equal and that. So hepatic S vein can be reduced, absent or reversed in restrictive cardiomyopathy. It helps in differentiating it from constrictive pericarditis, and the reason is here right atrial relaxation abnormal and right ventricular diastolic dysfunction is present. Sometimes AS and V wave, of course, can be retrograde and fused, and here is an example of that. Multiple reasons can cause for it. We don't have time to go through that. You can have coupled reversal of the D and A wave as shown here in a patient of constrictive pericarditis. That's an interesting phenomena, not described, but we have reported in our own cases, the dominant S wave and reverse D and A. That means early and late diastolic flow reversals, and they're not uncommon in patients with constrictive pericarditis. What Jesu has described is that if the A is more than D during expiration by 79% more, it has a sensitivity and specificity close to 90% diagnosing constrictive pericarditis. Here is an example. You can see very prominent, the S wave is of course prominent here, but what is important is that the A wave is very prominent during expiration compared to the D wave, and the ratio is more than 1, indicating this may be constrictive pericarditis. So hepatic vein V waves is prominent in constrictive pericarditis, TR, and hyperdynamic right ventricle, but normally people have not given too much attention to the V wave. Large retrograde waves are can be present. They are always abnormal, and you should look for abnormal hemodynamics. Sometimes, of course, you can have A wave marked variations with S wave preserved as here, and these are usually patients with constrictive pericarditis. This 21-year gentleman was sent with a diagnosis of chronic liver disease to us. So in constrictive pericarditis, hepatic vein Doppler in constrictive pericarditis has no specific pattern. However, A to D ratio more than 0.79 with respiratory variation is both sensitive and specific. Our experience says the S wave can be large, normal, absent, or reversed in patient with constrictive pericarditis. So ladies and gentlemen, to summarize, hepatic vein Doppler evaluation is a complex process, is a complex way to understand right heart hemodynamics, but it helps in assessing right atrial pressure, constrictive pericarditis, pericardial disease, fluid responsiveness, success of pericardectomy, tricuspid valve disease, and whether patient in ICU is volume depleted or volume loaded. Thank you very much.
Good morning, sir. Can you hear me?
Yes, I can.
I'm sorry that they unmuted me quite late. I have one doubt to you, sir. Say if a patient with constrictive pericarditis has already developed chronic liver disease, say like cirrhosis, is it dependable, that hepatic vein Doppler?
Yeah, no, it is not different. It is not different.
Okay.
Yeah, the only thing is that the velocities increase pari passu. S wave increases, D increases, but pattern doesn't change.
Okay, sir. Thank you. Let me see whether there is any question for you. I think there is no question from the audience. Is there any comment from Dr. Sudarshan Nagpal?
No, just continue. Dr. Mohan explained everything so nicely and so concisely. So he's happy. Very good. Thank you. Go ahead.
Hello, sir. Can you hear me?
Yes,
yes, I can hear you? Can you hear
Sir, let me ask another practical question. In your practice, do you use cardiac catheterization routinely to confirm the hemodynamics of constrictive pericarditis if you have good echo data?
This question?
Not routinely, but there would be 1 out of 10 cases where we'll categorize these individuals. And these are individuals who would have some discordance between clinical presentation and echo. One of the typical things could be that the BNP is markedly elevated. You would like to find out what you are dealing with. The other situation could be that you are not seeing any respiratory variation. You are not seeing in hepatic veins or pulmonary veins or in mitral flow. You are not seeing septal shift, and still the patient may benefit from, pericardectomy, and you would like to actually look. Obviously, the steps are more often echo, CT, right heart hemodynamics, and then you finally arrive at a diagnosis whether you should be sending this patient for surgery or not.
Okay, sir. I think we have 3 more minutes for discussion. Let me ask you one more question, sir. In conditions where there is a combination of constriction plus restriction, like cardiac transplant, rejection, or in such situations, is the hepatic vein Doppler reliable? That will it show both inspiratory as well as expiratory flow reversals?
The inspiratory reversals are not seen in about 10 to 20% cases of constrictive pericarditis, even in hepatic vein, in our own experience. And number 2, it is the S wave, which if the S wave is significantly reduced, there is myopathic element. There is always myopathic element. Now the question you may ask, it is a bad thing in case you don't have respiratory variation also and S is also decreased. Then you tend to go towards restrictive cardiomyopathy, or you go towards myopathic process, and many people would not get benefit of stripping the pericardium even though they have this thing. So my suggestion always would be that you look by CT the pericardium. Of course, thickness can be normal in 20%, but whenever in doubt, open up. Whenever in doubt, open up, because this is a curable condition.
Okay, sir. Thank you, sir. Thanks a lot for the wonderful presentation.
There seems to be some. So Shantanu is asking this question: does abdominal pressure can make a difference? So it is a very interesting question. The abdominal pressure actually increases. The venous abdominal pressure increases with obesity, and the extra venous pressure increases with obesity, and hence what it does is it pushes the blood. Actually, more blood is pushed from inferior vena cava to right atrium. Does it change the pressure? It doesn't change the pressure. It changes the gradient between the inferior vena cava and right atrium to some extent. That means inferior vena cava, actually the upper part of inferior vena cava, which is intrapericardial, tends to develop more negative pressure during inspiration. So the inspiration accentuation occurs whenever increased intra-abdominal pressure is there in obesity, but the pattern doesn't change in obesity.
Thank you, sir. I think we'll go to the next speaker. Hello, Dr. Rahul Mehrotra is here.
Yes, I am present.
Yeah. So the next talk is on right ventricular function structure and assessment by Dr. Rahul Mehrotra. Your first slide, please, sir.
Yeah.
So he's the director of non-invasive cardiology of Max Super Specialty Hospital, Saket. Without wasting much time, I think we can straight away go to the topic.
My screen is visible?
Yeah, it's visible. Okay, sir, don't waste your time. You can go ahead and talk.
Good afternoon, everybody. Good afternoon, sir. So I'll be talking about right heart dimensions, basic measurements of the right ventricle, and something about basic functions. So I'll restrict primarily to systolic function evaluation. So as we all know, the right side of the heart has not so well been studied in the past as well as being the left side. And there were several reasons for it why we were not looking at the right side of the heart routinely. Earlier, it was believed that the right ventricle plays a passive role and has no active role in circulation. So the data accumulation took time, and we still do not have as robust data for the right side of the heart as good and valuable data we have for the left side of the heart. It is not related to the body surface area. We do not have gender specific dimensions available with us. So these limitations should be borne in mind whenever we evaluate the right side of the heart. The other reason is the complex morphology of the right ventricle. It is a very complicated wraparound LV shape, either labeled as having a U shape or a crescent or in the form of a teapot with separate inflow and outflow separated by a body. Besides, most of it is behind the sternum, which is not amenable to imaging by echo very easily, and it is heavily trabeculated in its apical and the mid part. But we have made strides in echocardiography, and we are supposed to image the right side of the heart in all of our echocardiography imaging and report the parameters related to the right ventricle as well as right atrium. So normative data increasingly becoming available. The latest update we had was in 2015, where further data was made available. And prior to that, we had for the first time numbers and very comprehensive evaluation approach given in 2010 by the American Society of Echo, endorsed by ESCVI. So now we have a fairly standardized approach for looking at the right ventricle. We have the cutoff values, although with the limitations that they are not indexed to body surface, they're not ethnicity and gender specific. But having said that, we are able to quantitatively evaluate right ventricle, and it is now recommended that RV evaluation should be part of all the routine echo studies, taking into account the indication. The views are the standard views, but some modification should be made. So RV should be looked at from all the possible windows. This parasternal long axis view showing RVOT proximal part. We should look at the RV inflow view. The basal short axis view again gives access to measurements of RVOT. The short axis view at the papillary level where RV free wall can be seen surrounding the LV in the form of a crescent. And this is the most important view, the RV focused 4-chamber view, where we take several dimensions like RV basal, RV mid-level, and the length of the RV is measured. Subcostal view, even if we do not routinely make, we should try and make when looking at right ventricle, which should be done in all echo images. So these are the standard views, apical 4-chamber view, but RV focused, where RV focused view is the one where we are able to see the longest and the widest RV at the base. That is the right RV focused view. So by tilting the transducer a little bit, we should be able to make a RV focused view where RV is clearly in prominence. Besides, for the short axis view, just one glance in this short axis at the papillary level tells us that probably the RV pressure or volume overload is there, because the D-shaped ventricle cavity, LV cavity, is in the form of D-shaped, and septum being pushed gives us an immediate clue towards abnormal hemodynamics on the right side. So starting with the dimensions of the right ventricle, as I mentioned, these are a few of the dimensions. It is a complicated shape, so single dimension is not possible as we have for the left ventricle. The recommended are RV basal, RV mid, and long axis of the right ventricle. All these to be taken in end diastole in an RV focused apical 4-chamber view, which is already, as I mentioned, should be at the maximal dimension of the RV base. And these are to be taken in the inner edge to inner edge format and reported. So this is the RVOT dimension. We are able to see one part of RVOT proximal in plaques also. And this is the RVOT dimension taken in short axis view, perpendicular from the aorta to the inner edge of the RV free wall. This is known as the RVOT proximal. And this is the RVOT distal diameter just under the pulmonary valve. We're taking, again, all these are in end diastole and inner edge to inner edge dimensions. One of the important dimensions is for RV hypertrophy assessment is RV free wall thickness is been taken in subcostal view, and this is a zoomed image should be taken subcostal view, This should be taken at the level, again, end diastolic dimension, at the level where the anterior tricuspid leaflet is hitting the free wall of the right ventricle. So this is where we should be taking this dimension, taking care not to include the epicardium, part of the pericardium, ignoring the epicardial fat, as well as excluding the trabeculae and the inner part. So very meticulously in a zoomed image at the right location, end diastolic frame, we should be taking this dimension. And these are the normal cutoff values being proposed. Some changes were made in 2015 update. So we should update ourselves with these new cutoffs. RV basal diameter, anything above 4.1 is considered dilated. RVOT distal, again, more than 2.7 is considered abnormal, while RV free wall thickness more than 5 mm is considered abnormal. General recommendation is that in all our reports, we should include at least one of the RV dimension, preferably RV basal diameter, because it correlates well with the overall RV shape change or dilatation, while RVOT distal diameters may be included in some of the reports. Earlier recommendation was to include one proximal and one distal diameter, at least in all our reports. Similarly, subjectively, as I mentioned, when we look at the papillary muscle level LV, we will be immediately alerted towards abnormal hemodynamics on the right side because of the D-shaped cavity of the left ventricle, septum being pushed by the high volume or the high pressure on the right side of the heart towards the left side, giving it a D shape. So this is a subjective assessment, and if we measure the eccentricity index, anteroposterior diameter over septolateral diameter more than 1 is clearly abnormal, and it indicates the disease on the right side. So right-sided heart dimensions are important to measure. They have correlated with prognosis. For example, RA area, RA size correlates strongly with pulmonary artery hypertension prognosis. Similarly, RV dilatation has been correlated well with prognosis in COAD and acute pulmonary embolism. Similarly, RV hypertrophy, if it is seen in association with left ventricular hypertrophy in hypertrophic cardiomyopathy, adds to the value. Besides, it may be abnormal in other infiltrative cardiomyopathies. And thinning of the right ventricle is an important abnormality with microaneurysms or microaneurysm, which we look for when we suspect a patient as having ARVCD or very, very rare Wool's anomaly. So these are the basic dimensions of the right ventricle summarized. We should be including in our routine evaluation, and we should make a habit of taking these measurements in all our echo studies and reporting at least one dimension. In terms of basic systolic function evaluation of the right ventricle, there are several indices of global as well as regional parameters which have been included, but I'll go through some of the important parameters. Perhaps the most well validated and the most studied has been this very simple unidimensional parameter called the TAPSE, or tricuspid annular plane systolic excursion. Simply measured in the apical 4-chamber view, our M mode cursor is passing through the lateral tricuspid annulus. Fairly reproducible and reliable measure of global RV function, although this is representing only the longitudinal function of the RV, but this has correlated quite well with the global RV function, and any value less than 17 is reported to be abnormal, and this has correlated well with RV ejection fraction, which is a global parameter. Tricuspid annular velocity measured by tissue Doppler, or S prime, is also a relatively load independent measure, and an abnormal value less than 9.5 is to be taken as abnormal. It is also quite reproducible but less robust as compared to TAPSE, and it has not been studied, and it does not correlate well with patients with thoracotomy and post-op patients. So TAPSE remains the preferred, simplest, easier to do parameters. Color TDI also has come up, and there are few studies with a normal value of more than 6, again placing the cursor at lateral tricuspid annulus, but much less data is available with this, as is with myocardial performance index on the right side like we do on the left side. But this has again remained largely a research tool and only to be done in patients with pulmonary hypertension or follow-up when we already know that the patient has abnormal pattern on the right side. So more routinely done parameters are TAPSE and, if possible, TDI. The other measure of global RV systolic function is right ventricle fractional area change. Again, in the apical 4-chamber view, we track out the endocardial border, in the end diastolic frame, and then in the end systolic frame. And then with this formula, similar to ejection fraction, we are able to take the fractional area change, and a cutoff value of above 35 has been selected. Again, a global measure of RV systolic function, which can be taken if we are comfortable doing it. It is correlated well with MRI-derived RV ejection fraction and has been shown to be a marker of prognosis in heart failure, sudden death, stroke, and mortality in pulmonary embolism also. Volumetric evaluation of RV function is lagging behind on the right side as compared to the left side, but we have approaches which are now available with the help of which we can measure RV ejection fraction. Because of the complicated shape and historical reasons, we were not able to do it, but now we have automated software with the help of which 3D RV volume is being measured quite accurately and quite rapidly without lengthy and time-consuming measurements, and a normal cutoff of more than 45% for RV ejection fraction has been proposed. And this is an image of the automated way by which we are able to look at RV volume and other parameters related to RV like TAPSE, fractional area change, ejection fraction are also very rapidly made available by this automated software of the right ventricle available with one of the vendors. A strain again is available on the RV free wall as well as the entire RV. It is a measure of RV myocardial deformation and has correlated well with contractility, but there are significant variability in terms of the platforms, analytic software.
Dr. Rahul, you have already exceeded time. You have to quickly conclude the presentation because otherwise we won't give time for discussion.
So this is the last slide, and a normal cutoff of above 20 is proposed for the right ventricle. These are the normal parameters for the systolic function. TAPSE preferable, easy to do. We all should remember and include it in all our studies. I'll not talk about the IVC collapsibility, RA hemodynamics, and how we correlate RV pressure with RV-SP in terms of TR jet using RV pressures. So to summarize, comprehensive RV examination should be done in all patients, taking into account history, clinical information, and some parameters of RV size and function should be included in all patients, taking into account all acoustic windows available. Qualitative as well as quantitative assessment should be made. So with this, I end my presentation. Apologize for the exceeding the time.
Okay, thank you, Dr. Rahul, for the nice presentation. I have only one doubt. How do you take these measurements during inspiration, expiration, or during apnea?
This should be taken in quiet breathing.
Okay.
There's no recommendation of holding breath for these measurements.
Okay, okay. So though you have told that the TomTech software for 3D measurement of the RV is quite easy to perform, I always find it too difficult. The training was given to us by Amuthan sir, but still I find it really time consuming and difficult.
No, the green slides was with the TomTech and it was very time consuming, but the next what you saw with the blue animation was with the G, which now has this software which is requiring you to just place 5 points.
Okay.
One image that you acquire of 3D equal volume, and then place 5 points and you get this cast of the right ventricle with all the parameters listed in less than a minute.
Okay, so thank you, Dr. Rahul. I think we will go to the next speaker. Sudarshan sir, would like to take over?
Yeah, this was wonderful presentation by Dr. Rahul, and you coordinated very well. Now the next topic is for Dr. Amuthan. He is a professor of cardiology in Tamil Nadu. So I just straight away start the session. I request him to present his talk on 3D echo. Dr. Professor V. Amuthan sir. Yes,
thank you, sir. Thank you, Chairman sir, for your nice words. Now, the topic of the day is 3D echo, tips and tricks in recording and how to evaluate LV systolic function. As you know, LV systolic function has a central role in the evaluation of cardiac disease, guiding management and predicting outcomes. Numerous echocardiographic techniques, including left ventricular ejection fractions are used in routine clinical practice to assess this single left ventricular function. Now there are many problems with the assessment of left ventricular ejection fraction. So now what we have in addition to the left ventricular ejection fraction is global longitudinal strain, GLS, which can aid in the assessment of the LV systolic function. Now the comparison between the 2D and 3D, you can see here 2D is a flat view. This 2D is a flat view, whereas 3D has a pyramidal cone of tissue data set which can be acute. And what you see here on the left side is the 2D and this is the 3D. This is for example of the mitral valve in the short axis. You can see here this is the 2D, whereas 3D has the added dimension of depth. Now the advantages of 3D are it has realistic anatomical images which are possible with this, but the limitations are also there because 3D data set acquisition requires specific training, as our chairman was saying in the previous session, and the patients with arrhythmia and patients who are unable or unwilling to cooperate for breath holding may be posing difficulties. Now the most important point is the acoustic window. There should be a good acoustic window. Without a good 2D acoustic window, 3D may not be possible. So the most important thing is the good image quality, which is the prerequisite. And the advantages are that it avoids a foreshortened view of the left ventricle, and it does not rely on the geometric assumption, and end-phase views are possible with this. This is the depth analysis which you have to understand before going for analysis of these patients. Now in 2D you may not be capturing the true apex, whereas in 3D you will be having all the three true apex, and foreshortening error can be avoided very easily. Now for calculating the left ventricular ejection fraction by 3D, I will choose two vendors. This is the first vendor, which is GE, and you can see here the first thing is to select 12 tomographic slice view of the left ventricle. This is the left ventricle 4-chamber view. This is the 2-chamber view. This is the 3-chamber view. You can place the cutting points and you can select from the apex to the base. And you see that the whole left ventricle is captured within your acquisition window. This is the acquisition to keep the frame rate about 12 per second for doing a good left ventricular ejection fraction calculation, and it should be kept more than 33 frames per second for strain analysis, 3D strain analysis. Now first thing is to place 2 points, 2 markers, one at the LV apex and second point is at the coaptation point of the mitral valve, you can see here. And then the borders can be adjusted. This is for in diastolic volume, the borders can be adjusted. This is the 4-chamber view, this is the 3-chamber view, this is the 2-chamber view, and again you have to place 2 points for end systolic volume measurement, and one at the apex and another at the coaptation point, and these borders can be adjusted. So you have the end systolic volume and immediately you have the ejection fraction calculation which is shown to you on the other side. So that is very easy. This is from another vendor, that is Philips. The calculations on the previous equipments of the 1990s and 2000s were difficult, but with the development of the HOT model, the artificial intelligence is used here, and HOT model is very easy, and you can have the measurement of the ejection fraction in minutes. This is called as HOT model. And diagnosis of heart failure is mainly by the echocardiography, assessment of the ejection fraction in addition to the symptoms and objective evidence of cardiac dysfunction. And the therapy large part depends on the echo guided management, and you can see here echo guided management always has a good result, thereby avoiding the mortality in these patients. This is the advantages of calculating the ejection fraction by 3D. The advantages of 3D also is that you can calculate the global longitudinal strain GLS, 3D GLS in one go in the same patient. 3D strain has the advantage is that one apical 6-bit full volume can be obtained very easily, and most important, out of plane motion speckles which are seen with 2D strain calculations can be avoided. Thereby your results are more comparable to the CMR values. The time of minimal volume is calculated here for end of systole. So this is the strain, this is the longitudinal fibers which are seen in the endothelial internal areas. These are longitudinal fibers, these are the circumferential fibers. By 2D strain you have to measure only the speckles. Here small cubes or segments are used here for measuring, and in healthy individuals GLS from 3D echo is -18 to -20. GCS is -20 to -22, and global radial strain GRS is more than +40% respectively. So this is the calculation of the 3D GLS. It's very similar to your ejection fraction, and then you go for marking of the epicardial borders, and then the left ventricular myocardial mass can be calculated. The region of interest has to be marked for the strain analysis, and the speckle tracking is done in this way. It's a very easy method. You can have in a single go the longitudinal strain. This is the GLS, GCS, global circumferential strain, and global area strain. This is the added advantage of the 3D strain, that you have the calculation of this area strain. Whenever both longitudinal strain and circumferential strain are reduced, the area strain will also be reduced. And you have additional avenue of twist dynamics, the apical twist. The apex contracts in a counterclockwise manner, and the base contracts in a clockwise manner. This can be identified, and the twist of normal 7 degrees can be measured very easily. This is the normal cardiac function. This is the subendocardial fibers or the longitudinal fibers, and the subepicardial fibers or the circumferential fibers. So the early part of the heart failure, the longitudinal fibers or contraction is lost, and the circumferential fibers compensate for this by increase in their contraction. So that is lost again. This is what I was telling you. This is the GLS. When the GLS is reduced, the GCS is increased. This can be identified very easily by using the 3D techniques. And this is the carry home message that left ventricular ejection fraction calculations norms developed by the American Society of Echocardiography. For GLS it is -20. The ranges are given here, and the recent development of 3D strain echo speckle tracking allows calculation of the ejection fraction, volumetric analysis, and simultaneous measurement of multi-directional components of strain in a single 3D data set. 3D speckle tracking echocardiography has also been validated by using tagged MRI and sonometric reference standards. Now I will demonstrate one case of calculation of the ejection fraction right from the echo pack. This is the echo pack, and you can see here the controls are here. So this is a patient with the systemic hypertension, systolic hypertension. You can see here. This is the tomographic slices which I was mentioning. You can see here the tomographic slices from the apex to the base, and you have all the three segments which are coming here. And then go for the measurement, go for the left ventricular quantification, volume quantification, go for the LV quantification. First thing you have to align. You have to align this transverse line can be taken up, has to be placed in the center, and then end diastolic volume you can see here can be calculated by placing 2 points, one here and another in the center. And you can see here, similarly you have to calculate the end systolic volume. This is the end systolic volume you have, and this is how you place the end systolic volume. And then go for the volume waveforms. Volume waveforms are available immediately. The segmentation takes place. That takes some seconds, and then you have the calculation of the ejection fraction, 71%. So we can go ahead and calculate the global longitudinal strain also, but I think the time is up. Thank you, Chairman, for your time and valuable patience. Thank you very much for your for giving me the time to talk about the 3D, my favorite topic. Thank you very much. If there are any questions, Mr. Chairman.
Any questions? If there are no questions, we'll move to next talk.
Sorry, sir. Sir, can I interrupt? I have one doubt.
Yeah.
Yes.
Please.
Yeah, sir. In large left ventricle, like in chronic severe MR or chronic severe AR, we often find that some part of the LV will be cut off. So how will you circumvent such an issue?
You can increase the angle of the width of the. You can increase the width of the angle. While doing the 2D, increase the width and then select that.
Okay, but there will be some frame rate issues, isn't it, sir?
Frame rate can be increased by increasing the number of frames you select.
Okay.
That is the multi-frame selection of the ECG. Usually you select 12 frames per second for doing the ejection fraction calculation. If you want to increase the frame rate, you can increase the number of the ECG segments which are analyzed. You follow what I say?
Yeah, yeah. Okay.
See, usually you select 2 images, so so that you have 12 to 13 frames per second. If you select multiple ECG cutoffs, that is a 4 or 6 frames, 4 or 6, then you have the 30 to 48 frames per second. So that is how you adjust.
Have you noticed any vendor differences between the Philips and the GE in calculations?
Calculations, initially, the initial days when I worked with IE33, it was a difficult job with the Philips, but I loved that machine and we used to do a lot of ejection fraction calculation, and most of my textbook was written based on that. And then we got the GE machine. GE machine makes matters very easy. Just place 2 points, one in the apex, one in the coaptation point, you are done. You just adjust, you have that. Now in Philips, you have the hot model. It's very easy, similar to your GE machine. They have artificial intelligence. So when you opt for a GE machine, Philips machine, always ask for the hot model. Don't buy 3D equipment Philips without hot model. If you have hot model, it is very easy. You have LA volume, you have LV volume, and they are going to come out with RV volume also. So artificial intelligence is used.
Okay, sir. Thank you for the wonderful talk.
Sorry for the interruption. We are short of time actually.
Thank you, sir.
Next speaker, Dr. Devika Chatterjee. Is she there?
Yes, sir.
Yes, Doctor. Welcome, Dr. Devika. Your talk is on transesophageal echocardiography. So
Yes, sir.
Straight away you can start your talk on transesophageal echocardiography and its applications.
Okay, thank you, chairpersons, and good afternoon, everybody. I'm going to talk on the basic views and applications of transesophageal echo, where we place a probe in the esophagus of the patient to look at the heart. And this is because esophagus lies immediately posterior to the heart, for which we can use a very high frequency ultrasound crystals to get high resolution image like this. Now, before I go to the views, let me show you the equipment in short. The equipment is a gastroscope basically, at the tip of which an echo transducer is mounted. Imaging surface is demarcated by a circle or a square. It has got a handle on which two wheels are there to move the tip, and 2 buttons to move the imaging sector between 0 to 180 degree. We make various manipulations, like we push the probe to advance, pull it to withdraw, and shaft can be rotated to the right to see the right-sided structures clockwise, or to the left or counterclockwise to have a look at the left-sided structures. And we move the tip of the probe. We can antiflex or retroflex the tip by clockwise or counterclockwise rotation of the big wheel, and lateral flexion is done by the rotation of the small vein. And the most important manipulation is the rotation of the imaging sector between 0 to 180, 180 to 0. This basically changes the ultrasound beam, and as a result of which the view changes. As you can see, as I'm changing the angle, the view changes. And this way we acquire standard views at standard angles, but we may require increase or decrease by 5 to 20 degrees with slight rightward to leftward rotation of the shaft of the probe. The standard views are upper esophageal, mid-esophageal, and transgastric. We always start with the mid-esophageal. Then we go to the transgastric and end the test with upper esophageal, as because we cannot keep the probe in the upper esophagus for a long time as it gives gagging reflex. While inserting the probe, we must be sure that the imaging surface of the probe is facing the tongue of the patient. And in the oropharynx, I get a resistance at level of cricopharynx. I apply gentle pressure to cross that resistance. And as I cross the resistance, I start getting picture in the monitor, first in the upper esophagus, push a bit to go to the mid-esophagus. And here I get the mid-esophageal 4-chamber view at 0 degree, which is the most valuable, easiest to obtain view with minimal to no manipulation, and it mimics the apical 4-chamber view of the transthoracic echo. One can see LA, LV, RA, RV, along with mitral valve and tricuspid valve in this view. And this view is used to identify the etiology of the MR. As you can see, there is a significant eccentric jet of MR, the cause of which is the caudal rupture in the AML, resulting in flail AML. And we can see the vegetation in infective endocarditis here in the PML, 2 vegetations. And here there is an abscess along with the vegetation in the tricuspid valve. The next mid-esophageal important view is the aortic valve short axis view, which is obtained at 40 to 60 degrees, as you can see. And this mimics the short axis view of transthoracic echo. We can see 3 cusps of the aortic valve. This view is used to confirm the diagnosis of bicuspid aortic valve. And next to it, the important view is the long axis view. As you can see, we get it by changing the imaging sector to 120 to 130 degree, and it mimics the parasternal long axis view. Here we can see LV inflow, LV outflow, aortic valve, aortic root, ascending aorta, A2P2 scallops, LA, LV, and part of the RVOT. And this is the view where we take all the measurements of the aorta. And also we see the different pathologies of the aorta. Like here you can see there is a dissection. Here you can see the intimal flap, and the enlargement, aneurysmal and dilatation of the ascending aorta, vegetation in the aortic valve. Since we can see the A2P2 scallop, we can also comment on the prolapse of these 2 scallops in this view. Like here, there is this prolapse of P2 scallop giving rise to the anteriorly directed jet of MR. And next to it, a very important view is the bicaval view, which we obtain at 90 degrees by changing the imaging sector to 90 degrees and turning the shaft a bit to the right of the patient, as you can see. And as soon as we do that, we see the LA at the top, RA at the bottom, IS in between, and SVC and IVC draining into the RA. Here is the Eustachian valve. And we use this view to diagnose and also to assess the SVC IVC rim before doing device closure of ostium secundum ASD, to diagnose sinus venosus ASD, which is very difficult by transthoracic echo, PFO, and very important uses during cardiac intervention to guide the interventionist for transseptal puncture to gain entry into the LA. The mitral valve scallops, A2P2, can be seen in the mid-esophageal 4-chamber view. And if we slightly withdraw from this level, we see the LVOT opening and A1P1 scallop. And if we slightly advance the probe, we see the coronary sinus at the back and A3P3 scallop. And in the commissural view at 40 degrees, we see the P3 on the left, P1 on the right, and A2 in the middle like a trapdoor. And in the bicaval, in the mid-esophageal 2-chamber view, which we obtain at 90 degree. But unlike bicuspal view, no rightward turning of the probe, we see a small P3 on the left and a big part of the AML showing A3, A2, A1. And next is a very important view is the LA appendage, which we can obtain at 90 degree or at 0 degree just by pulling the probe from the mid-esophageal fourth chamber. This is to identify the thrombus in case of mitral stenosis, a contraindication for BMB, and also a contraindication for cardioversion. And pulmonary veins are seen. This is the left pulmonary vein at 45 degree beyond the reach. And both the veins can be seen at 90 degree to 120 degree by extreme leftward rotation of the shaft. And both the right pulmonary veins can be seen at 45 degree by extreme rightward rotation of the shaft. From this view, now we'll go to the transgastric view. Now, before that, we go back to mid-esophageal fourth chamber at 0 degree, and we make sure that probe tip is in neutral position. It is neither antiflexed nor retroflexed. For that, we reset the wheels in the extreme left and lock them and keep these markers on the wheels aligned together. Then we push the probe very gently and slowly down the esophagus to reach the stomach. Now, as we push the probe, you can see, we see the coronary sinus in the background. Here is the coronary sinus. This is the landmark of gastroesophageal junction. From this level, we push further very gently. And then as we push, we see the liver reach the stomach. And then we antiflex the tip slightly and pull it. We are at the basal transgastric view at short axis, showing the mitral valve area, orifice, PML, and the AML. And if we go a little further, we'll get the transgastric view, mid-transgastric view at 0 degree, where we can see the papillary muscles, and we can comment on the wall motion abnormality and the LV systolic function. Now, from this view, if we go to the 120 degree, as you can see here, we open up the LV outflow tract. And here, aortic valve flow is absolutely parallel to the cursor. So an ideal view to get the accurate pressure gradient in aortic stenosis. Now, to go to the deep transgastric, we go back to 0 degree and then push the probe further down. And then we sharply, fully antiflex the tip to open up the LVOT. This time, LVOT opens on the extreme left side of the picture. Here again, aortic valve flow is parallel to the cursor, and another ideal view to get the accurate pressure gradient. Now, from this is the end of transgastric views, basic transgastric views. Then we'll go back to the mid-esophageal again. So before that, we must make sure that the probe tip is in neutral position, neither antiflexed nor retroflexed, by resetting the wheels, as I mentioned earlier. Then we pull out the probe slowly from the transgastric to the mid-esophageal, and we get the mid-esophageal fourth chamber view at 0 degree. Now, at this level, we turn the shaft of the probe to the extreme left to get a circular short axis view of the descending thoracic aorta, and which appears beyond the LA. And then we decrease the depth to have a very good look, and we rotate the multiplanar angle to 90 degree to see the long axis. So here also you can see the atheroma or dissection. Now, to go to the upper esophageal view, from these levels, short axis descending thoracic aorta mid esophageal view, we start pulling the probe to see the upper esophageal aortic arch views. Now, though we can't see a very large part of the arch because it's a blind spot, as trachea intervenes between the esophagus and the arch. So we start pulling, and as the probe reaches the arch, it becomes elongated, as you can see here. And if we rotate the multi-beam angle to 90 degree, we get the short axis with the origin of left subclavian artery at 3 o'clock position. So with right and leftward turn, we can see the atheroma, calcifications, or even the dissection of aorta. As you can see, these are the intimal flaps. So this is the end of the test. the basic views. In between, there are multiple views, but I have just shown you the basic views, and we end the test. We cannot keep the probe very long time in the esophagus, in the upper esophagus, so we draw the probe from the upper esophagus very slowly and gently through the mouth guard, as you can see. So to end my talk, I would say that we should not forget that it is a semi-invasive procedure. So there is a chance of injury like laceration in the oral cavity, esophagus or stomach, or even very rarely esophageal perforation. But we must remember it's a very life-threatening complication. So we need to have very good orientation in instrumentation, and we should move the probe very gently and softly to end the test without any complications. Thank you.
Good. Thank you very much, Dr. Devika. Very nice presentation and shown all the views. If there are any questions, Dr. Devika would be happy to answer. Any questions? Dr. Rajesh?
Yeah.
Can you hear me? Yeah.
Since there are no questions from the audience, so first of all, I will appreciate, madam, if you have wonderful pictures. You have shown all the beautiful pictures here. One doubt.
Yes.
See, when you are evaluating the upper mid-esophageal views, how can you demonstrate the left pulmonary artery? Is there any method? I know that it is almost impractical because of trachea overlying, but is there any way you can show it?
Yeah, yes, Dr. Nair. As from the mid-esophageal fourth chamber, as you withdraw the probe, time will come, you will see the aorta in the center and pulmonary artery. And from that level, if you rotate the probe a bit, rotate the shaft of the probe to the left, we usually see the left pulmonary artery. Nicely. It's very difficult. We usually see the pulmonary arteries from the transgastric views, which I couldn't show because time is short.
Okay.
But it's really possible to see from the transgastric also. Like if you go, you open up the RVOT and it's possible. Even in the upper esophagus, you can see.
Okay. Now you have we have 2 more minutes. Any other comments? Now, one comment is, see, we are often summoned to the cardiac surgery theater to do transesophageal echo. But now I have noticed that many of the cardiac anesthetists are also very good, they are much more experts than us. But sometimes, whenever they have doubt, they will summon us to the theater. What I have found is in 2 situations, especially after mitral valve repair and after the ventricular septal rupture repairs, I think we should be very careful because the heart is only is only contracting, only picking up. The blood pressures are very low. We are likely to miss all these pressure dependent shunts. Like we may miss, I have missed. Initially, I told them there is no residual VSR, but then after a few minutes, I have seen big residual VSR. So we should be very careful in the cardiac surgery theater. That's a comment from my
shunt is a small shunt is very difficult to visualize in transesophageal echo. Color flow is sometimes is a problem. But usually in the OT, the patients are under anesthesia, full anesthesia. So I find it much easier.
Easier to do.
Especially for the valves, prosthetic valve, or to look for paravalvular leak and all.
Yeah, actually, I have taken all the transgastric views only in the cardiac surgery theater.
Yes.
Okay. I think we are on time. Thank you all the speakers. Any more comments?
Thank you, Dr. Rajesh, for wonderful conduct of the meeting. Everything finishing on time. We'll move on to the next session.
Thank you, sir.
Dr. Harin Vyas there?
Yes, I am here.
Yeah, Dr. Harin, Dr. Balasubramanian has excused himself. So you
Sure.
will have the show all to you, and I'm sure you will manage quite perfectly.
Sure, we'll try to keep it in time.
We'll start with the first speaker.
Sure.
Can the first speaker come on, Dr. Gaurav Agarwal, and share your screen, please? You're losing time.
So I understand Dr. Gaurav Agarwal is from Bangalore, and he's going to talk about intramyocardial dissecting hematoma. Let us hear from Dr. Agarwal about his case on this rare but interesting pathology. Dr. Gaurav Agarwal, are you there?
Sir, he's exit.
He's exited, is it?
Yes.
Because I could see him earlier. So shall we, do we have the next speaker? Dr. Arun Gopalakrishnan. Is Dr. Arun Gopalakrishnan available?
Please unmute him.
Sir, he is unmuted.
So is that Dr. Gopalakrishnan? Dr. Gopalakrishnan, we welcome you to this virtual conference. And Dr. Gopalakrishnan is from Thiruvananthapuram, Kerala. And he works as an assistant professor in the Department of Cardiology, Pediatric Division. And he is going to present rhabdomyoma in neonates. So we welcome you, and please start with your presentation.
Sir, his audio is not there.
We are not able to hear you, Dr. Gopalakrishnan. We can see your screen. Is there a technical?
Dr. Gopala, could you please disconnect your earphone?
Can the technical team call him and figure out what's going on? Maybe there is some setting issue. I think Dr. Agarwal is back, Dr. Gaurav Agarwal.
Yes, sir.
Are you ready with your presentation?
Yes, sir. Yes, sir.
Yeah. Okay. So we welcome you, Dr. Agarwal, for this virtual conference.
Thank you, sir.
I did introduce you, but then we lost you. So without wasting any more time, please start with your interesting case on intramyocardial dissecting hematoma.
Sure, sir. Sure. Thank you so much, sir. My screen is audible, sir?
We are able to see your screen, but we cannot see the presentation. I think you need to open it.
Now you can see the presentation?
Yes, I can. Yes.
I'll be starting, sir.
Sure.
Good afternoon, everyone. I'll be presenting briefly on a case of left ventricular intramyocardial dissecting hematoma. I am Dr. Gaurav Agarwal, DM Cardiology from Sri Jayadeva Institute of Cardiology, and currently working in my parent institute, that is Sri Jayadeva Institute of Cardiology, and I am designated currently as a post-DM senior resident in the Department of Cardiology. Moving on to the history, a 45-year-old man, an active tobacco smoker with history of diabetes and hypertension, presented to us with a recent onset of NYHA class 4 heart failure. He had sudden onset chest discomfort 1 month before, which resolved spontaneously within a day. There was no significant past medical history relevant to the current presentation. On examination, he had tachycardia, BP of 80/60 mmHg, elevated JVP, anasarca, S3 gallop, and hepatomegaly. ECG showed sinus rhythm with right bundle branch block and low voltage QRS complexes in limb leads with T inversion in leads V1 to V6. We did a 2D echo, and in the parasternal long axis view, you can make out here that the entire interventricular septum is akinetic, the LV cavity is dilated, and there is a large heterogeneous mass which is present within the LV cavity, which has differential echogenic texture, and there are some dense areas with some echolucent areas, and there is a mobile flap within the true LV cavity, which we presume to be the endocardium, and these multiple layers we presume to be the dissected muscle in between which multiple layers of hematoma have collected. Similar thing could have been made out in the modified short axis view, and here you can see that nicely the mobile endocardial flap and the multiple layers of muscle through which dissection has happened, and there are multiple layers of hematoma in between. Similar thing was shown on the apical four-chambered view, and in the color Doppler images, you can make out that there is no leak of blood from the true LV cavity into the neo formation, nor there is any leak of blood from the interventricular septum or the LV free wall. So there is no rupture. We did a 3D echo, and here you can make out this image clearly shows that this is the mobile endocardial flap, and these are the multiple muscle layers through the LV myocardium through which dissection has happened. And this is the trapped hematoma, and towards the apex there is another layer of organized hematoma. We did a contrast echo to see whether there is any leak of the contrast or not, and here you can clearly make out that this is the true LV cavity which is filled by the contrast, whereas there is no leak of contrast at all into the neo formation. We got an MRI done, and the MR sequences confirmed the diagnosis of intramyocardial dissection. And here you can clearly make out this is the this is the endocardial flap, and these are the multiple layers of hematoma and thrombus within the LV cavity. And this is the most apical one is the organized thrombus, which has been long standing from almost a month. And these are partially organized thrombus and hematoma with multiple layers of muscle in between. And similar thing can be appreciated on the axial image as well, this being the thrombus. The late gadolinium enhancement MRI images showed that the entire anterior wall is thinned out, akinetic, scarred, and non-viable, and it is surrounding the intramyocardial hematoma. Thereby, with the possibility of intramyocardial hematoma, with the dissection, we kept the possibility of three differentials in our mind. The first being a pseudoaneurysm, but the distinction of a intramyocardial hematoma from a LV pseudoaneurysm could have been made out clearly with the fact that in case of a pseudoaneurysm, there is a complete rupture of the myocardial wall and it is surrounded by pericardium only. Whereas in case of a intramyocardial dissecting hematoma, we could make out that it was surrounded by the myocardium, the epicardium, and the pericardium. The next differential that comes to mind is the intracavitary thrombus. But in case of an intracavitary thrombus, there is no systolic expansion, and it is not surrounded by an endomyocardial border towards the LV cavity. Whereas in case of a dissecting hematoma, as we saw in our case, there was an endomyocardial border which was floating within the true LV cavity and was having systolic expansion. And the third differential that comes to mind is prominent ventricular trabeculation, which are characterized by an irregular ventricular wall with seepage of blood in between the ventricular wall, which was not in our case. Thereby, we kept the diagnosis of LV dissection with intramyocardial hematoma and severe LV dysfunction with the patient currently in acute decompensated heart failure. And we stabilized the patient with inotropes and diuretics. And subsequently, the heart team was consulted. But owing to the complexity of dissection and the prohibitive risk for surgery, that is a Euro score of around 65%, hematoma evacuation and ventricular wall repair would have been challenging. Thereby, the patient was kept on conservative management and he was discharged 2 weeks later on diuretics, ramipril, atorvastatin, and aspirin. At present, at almost 1 year of follow-up, the patient is symptomatically better in NYHA class 2 with no further extension of the dissecting hematoma. Moving on to the discussion, intramyocardial dissecting hematoma is a rare complication of myocardial infarction, trauma, and PCI. It can develop in the LV free wall, the right ventricle, or the interventricular septum. A dissecting hematoma consists of a cavity filled with blood, the outer wall of which is the myocardium and the pericardium, as we saw in our case, and the inner wall facing the ventricular cavity is the myocardium and the endocardium, the mobile flap, which was seen in the videos. In our patient, the most likely cause of LV dissection was myocardial infarction, as the patient had multiple risk factors for ischemic heart disease, including diabetes, hypertension, smoking. In more than 90% of the cases, rupture occurs after the first MI. It has a strong correlation with single vessel disease, reflecting lack of collateral circulation. Management depends on multiple factors, including the age of the patient, hemodynamic status, size of the hematoma, presence of ventricular septal rupture, and LV function. IDH limited to the apex is usually managed conservatively, whereas those patients with expansion of dissection, ventricular septal rupture, compromised hemodynamics, and low LVEF with anterior wall MI should undergo surgery. In a case series by Letman et al., published in 2018, 42 cases of intramyocardial dissecting hematoma have been diagnosed and published so far. In this series, in-hospital mortality was 23%, and the strongest independent risk factors for mortality were low EF, that is EF of less than 35%, age more than or equal to 60 years, and anterior wall MI, and late presentation, that is more than 24 hours after onset of symptoms, was also associated with increased mortality. Take-home message: intramyocardial dissecting hematoma is a rare complication of myocardial infarction and a diagnostic challenge. Delayed presentation can mimic LV clot on transthoracic echo. Low EF, age more than 60 years, anterior wall MI, cardiogenic shock, and late diagnosis are predictors of in-hospital mortality. Conservative management is the usual approach in cases with small hematomas localized to the apex, and cases with hemodynamic instability, VSR, and expanding hematomas may need surgical repair. We recently got this case published in JACC case reports in the month of October this year itself, and these are my references. Thank you.
So that was a wonderful presentation, Dr. Agarwal, and you kept it in time.
Thank you, sir.
So basically what you are trying to highlight is your eyes doesn't see what your mind doesn't know.
Yes,
you know,
sir.
so this may be not that rare, but because we don't think about it, we may not be able to pick it up, and you have nicely demonstrated with contrast and MRI. So
Yes, sir.
that was a very, very good case.
Thank
So
you so
let's move. Are there any questions?
We'll move on, Dr. Vyas. We are short of time. We started a little late.
Sure. Right. So let's move on to the next speaker.
Am I audible now?
Yes, we can hear you now.
Okay, thank you.
Yeah.
So I'll show the case of rhabdomyomas in a neonate. This was regarding a term newborn weighing 3.1 kilograms, and the antenatally at term multiple cardiac masses were noted on the ultrasound, and the parents were counseled regarding grim outcome for the baby, and with no active interventions was the counseling which was given to the from the gynecology side. And the child was born and observed in the newborn ICU in the adjacent institution, and child was comfortable on day 1. On day 2, child became breathless with desaturation to 70%. Child was ventilated, and there was a call for takeover. The saturation 70% on room air. After ventilation with an FiO2 of 80%, saturation improved to 98%. And this was the echocardiogram on day 2 of life, which showed multiple cardiac masses occupying almost
sorry, Dr. Gopal, I'm just interrupting you because we are not able to see your screen. I can see you, I can hear you.
Okay,
but I can't see your screen, so you'll have to share your screen.
Yeah, okay.
Yeah, we can see it now.
Okay. This was a 3.1 identified to have multiple cardiac masses at term, and the parents were counseled regarding grim outcome. After birth on day 2, the child developed breathlessness and desaturation, and the child was ventilated, and we received a call for takeover. The saturation was 70% on room air, which improved to 98% on ventilation with 80% FiO2. This was the echocardiogram on day 2, which showed multiple large cardiac masses occupying almost the entire left and right ventricles, and with marked obliteration of both the left ventricular and right ventricular cavities. This is the apical four-chamber view, a close-up showing the left ventricular inflow. The mitral valve movement was considerably affected. Masses were attached to the subvalvular apparatus of the mitral valve, limiting the coaptation of the mitral valve leaflets. This is the parasternal long axis view showing almost completely obliterated left ventricular cavity, large masses in the left ventricular free wall, interventricular septum, and in the right ventricle attached to the free wall. The left ventricular inflow obstruction is clearly evident. We got a mean gradient of 3. This is the modified parasternal short axis view, which shows the altered alignment of the right ventricular outflow tract because of large masses in the right ventricular outflow tract. The entire orientation of the pulmonary artery and the pulmonary valve and the pulmonary arteries were altered. There was this is a short axis projection which showed that there was a small patent arterial duct which is flowing entirely right to left. So we diagnosed that this child had multiple cardiac rhabdomyomas, masses, most likely rhabdomyomas. There was left ventricular inflow obstruction and the child was in heart failure. The child was noted to have ash-leaf macules in the back. So we made a diagnosis of probable tuberous sclerosis, and with the duct shunting entirely right to left and with desaturation on room air, we diagnosed persistent pulmonary hypertension of newborn. This child on ventilator was started on sildenafil 1 mg per kilogram per dose twice daily. The child was weaned on the second day after intubation and extubated thereafter to room air, and the saturation improved to 100% on room air by day 7 of sildenafil. We discussed regarding the options of management at the joint cardiac meet, and it was refused by the surgeons considering very high surgical risk with masses involving the mitral valve and extensive resection in a 3.1 kilogram baby. So we arrived at a consensus decision to commence on oral everolimus therapy in the background of limited literature that is available on this therapeutic regimen. So we decided to administer 0.75 milligram per week to the baby of oral everolimus after informed consent from the parents. And tuberous sclerosis is an autosomal dominant disorder which involves overactivation of the mTOR pathway, and this is postulated to be the reason for multiple hematomas, angiofibromas, renal angiomyolipoma, and rhabdomyomas in the body. And everolimus is an mTOR inhibitor, and while it has not received approval for use in cardiac rhabdomyomas, there is FDA and European Medicines Agency approval for tuberous sclerosis associated ependymal giant cell astrocytomas and renal angiomyolipomas. So oral everolimus was instituted in this baby. There is an ongoing multicentric randomized controlled trial by name the Oracle trial, which recommends 4.5 milligram per meter square per week, which may be administered for 3 to 6 months. And we have to explain the risk of protracted infections like varicella, tuberculosis, or pneumonia, monthly echo and arrhythmia screen for the baby, and we should avoid live vaccines during this period. So during follow-up, this is what we noted at 3 weeks of everolimus therapy. The left ventricular inflow obstruction was eliminated. There was decrease in size in the cardiac rhabdomyomas. The right ventricular cavity is also larger. This is the apical view, which clearly showed that there is no left ventricular inflow obstruction, although there are residual masses in both the left ventricle and the right ventricle. The altered configuration of the still persisted because of the mass in the RVOT. At 5 weeks of everolimus therapy, we had almost complete regression of masses in the left ventricle. The left ventricle started gaining a normal contour, though there was masses attached to the interventricular septum. At 6 weeks, the ventricles are almost normal with much smaller residual masses. This is the parasternal long axis view at 6 weeks of everolimus therapy, as opposed to the figure we had seen on day 2 of life. By this time, at 6 weeks of life, we were forced to stop everolimus because the child developed skin erythema, skin scaling, and papillar rashes consistent with miliaria rubra. This was extensive all over the body. There were no blebs or weeping lesions. We did blood investigations, which showed that there was eosinophilia with absolute eosinophil count of 1,460. Other lab reports were normal. And the child was managed with the body cleanser lotion, sulfur-free baby shampoo. And at last follow-up, that is 2 days back, at 7 days of stopping everolimus, there is a 60% improvement, and the child continues to remain on follow-up. So take-home message is that oral everolimus therapy can accelerate regression of large cardiac rhabdomyomas without surgery in tuberous sclerosis, and serial echocardiography is recommended for these children. We need close monitoring and follow-up, and also we should follow up the results of the Oracle multicenter randomized trial to get conclusive evidence before a recommendation can be made. Thank you.
Thank you very much for keeping in time. It was a wonderful presentation with very scary looking images. I think keeping the time in mind, we will move on to the next presentation, which is by Dr. Ganeshan Nambirajan from Madurai. And Dr. Nambirajan is going to talk about atypical COVID-19 myocarditis. So we welcome you, Dr. Nambirajan, and you can please share your screen and start the presentation.
So very good afternoon, everyone. Respected chairperson, seniors, and friends. Sir, I am audible?
I can hear you. Yes.
Sir, are you able to see my slides? Hello, sir.
We can see you.
Yeah. So during the previous months, during the course of pandemic, there have been reports of late immunomediated myocarditis and multi-system inflammatory syndrome occurring in many children and young adolescents, and also in adults. These reports have been increasing in the last 3 months. Although COVID manifests predominantly as a respiratory disease, more cases regarding myocardial injury is being reported now. This infection predominantly, when it occurs in children, is mostly mild and non-fatal. But if it is associated with multi-system inflammatory syndrome, these can lead to serious illness and long-term side effects. I am here to present 2 healthy young females who presented to us with mixed cardiogenic and vasogenic shock and cardiac injury without predominant initial respiratory symptoms. The case 1 is the 15-year-old female who was residing in Mumbai for the last 10 years. He came to our city in Tamil Nadu following the outbreak of COVID-19. At the time of arrival in Tamil Nadu, when she was tested, the COVID was negative, but many family members had positive COVID virus at the time, and they were isolated and treated. 1 month after that episode, she developed symptoms of throat pain associated with severe dyspnea and breathlessness, and she referred to us for further management. On the day of admission, she was completely afebrile. Her pulse rate was 110 per minute, and the BP was 90/70. Physical examination revealed bilateral crepitations, and she was very dyspneic and with gallop rhythm. She denied any symptoms prior to this event and had a very good effort tolerance during the preceding period. She was healthy during the previous period. This is a ECG showing sinus tachycardia with poor progression of R wave in the V1 to V6, and X-ray shows evidence of pulmonary edema and cardiac enlargement. And due to the COVID pandemic which is going on, we once again tested for COVID RT-PCR, which turned out to be negative, but the IgG titer was highly positive for COVID virus. And echo showed globally dilated LV with severe LV dysfunction and moderate MR the ejection fraction was around 20% and minimal pericardial effusion. You can see the dilated LV and severely dilated LV with severe LV dysfunction. And this also showed the EF around 20%. You can see and she had markers, both the markers of thromboinflammation. So the markers of thrombo and inflammatory markers are highly elevated. D-dimer, CRP, ferritin, all are elevated, including interleukin. And after stabilization, she underwent a cardiac MRI to rule out any evidence of myocarditis. It showed evidence of diffuse myocardial edema, you can see, and there is on the T2 weighted images and late subepicardial mid-epicardial myocardial enhancement suggestive of myocarditis. So initially we thought it could be a simple idiopathic DCM of unspecified etiology, but against the background of elevated markers of thromboinflammation, we thought, and myocardial MRI supporting, we thought it could be a case of late immune-mediated myocarditis. And so it fulfills the criteria of lately criteria of diagnosing myocarditis, this case. And this patient was managed with inotropic support and diuretic and steroids, and 1 week later her symptoms completely abated and she improved and discharged. And regarding the second case, she is our critical care nurse working in a COVID ward. She completed her COVID duty 1 month back. She was hale and healthy, was perfectly well before this illness. Presented with history of fever for 3 days, severe abdominal pain, vomiting, and diarrhea. And initially she was suspected to have food poisoning, and she was admitted and evaluated. Next day, on the day of admission, she developed severe hypotension, giddiness, and she was started on IV fluids, and suddenly developed her condition worsened, and she developed respiratory distress, and she was intubated. When further evaluation revealed she also had acute cardiac injury and acute LVF, and this is and we was diagnosed to have severe LV dysfunction. And initial CT scan chest was perfectly normal on the day of admission. The CT abdomen showed features of enterocolitis. There is the entire bowel, small bowel and large bowel were thickened, and there were features of enterocolitis. And this is the ECG showing a sinus tachycardia. And she also had this RT-PCR was negative, IgG antibody was strongly positive for that. And you can see the thickened bowel loops entire. So initially we thought it could be a toxic shock syndrome due to some enterocolitis, but when the results came, she also had elevated, all the thromboinflammation markers were highly elevated. And this is the echo showing a kind of dilated LV with severe LV dysfunction. The myocardium is thickened and there is a mild even pericardial effusion. This is both the fourth chamber and the two parasol long axis showing severely depressed LV dysfunction. And she had an interleukin around 275, and both the patients had a low lymphocytosis, which suggests that this patient is having a hyperimmune response due to the COVID-19 infection. This is very hallmark of this. These patients preferentially have a neutrocytosis, whereas the lymphocytes are grossly reduced. This is another hallmark. And this patient, both the patients have similar parameters. We encountered these two patients in the last 2 months, and we thought it was worth sharing with this audience. So we thought this patient characteristically fit into the history of multi-system inflammatory syndrome. She is around 21. She fulfills the criteria to be in children, multi-system inflammatory syndrome in child. This enterocolitis has been also reported in COVID infection, and it can be a sequelae of this. Extrapulmonary manifestations are now becoming very common, and it occurs in patients without significant respiratory illness. So both the patients were managed with standard protocol, and both were recovered inotropic support for a long time, and both were with steroids. Both the patients recovered well. And she's the second patient is still in ICU. She's recovering. Compared to the admission, she's far better. Few words about immune-mediated myocarditis. Even though there have been few COVID-related reports of isolated myocarditis, without febrile illness and respiratory involvement. This is traditionally it occurs in children and adolescents. So every child should be followed up during the, even though they have a mild infection in the initial period, they should be followed up in the next 2 months, whether sometimes they can develop this immune-mediated late myocarditis. The prevalence is still not clear, but it could occur in 8% of patients with COVID-19 infection. 30% of patients can have fatal end if they are not treated properly. And the pathophysiology, it is a host immune-mediated damage, not the direct viral damage is not that common, but it is a host, it's a hyperimmune mod adaptive hyperimmune-mediated damage, which is the cause of myocardial dysfunction in these patients. So this figure just shows that direct damage caused by this virus due to the is very rare, but only the indirect damage caused by the cytokines and the chemokines are which is responsible for myocardial damage in this patient. So the PAN problem is the endotheliitis, which leads to all these events in this patient. Most of the time, this patient may have a near normal troponin level. That means this illness occurs 3 to 4 weeks after the initial infection. So we should be very careful in our patient. So there have been even reports, this Germany study showing around nearly 20–30% of patients can have evidence of myocarditis when they are subjected to MRI, even if their patient have a totally asymptomatic. So every patient should be followed in this period.
Okay.
Okay, thank you, sir.
Yeah, so that's a good presentation. And last 6–7 months, we have seen all weird and wonderful thing with COVID, and this adds to that. So keeping the time in mind, I would like to invite, thank you, Dr. Namirajan, for a lovely presentation. And I would like to invite Dr. A.V. Anjaneyelu from Hyderabad. And the doctor has a wonderful case where he says modified views saved the day.
Thank you, sir.
So I welcome you, sir.
Thank you. Let me
start.
Presentation. Are you able to see the slides?
Yes, we can.
Yeah, today I'm going to present a case of interesting congenital heart disease, which exemplifies the importance of picking up important clues and, if necessary, modified views, and if necessary, a second echocardiographer, not to miss important findings in this study. So this is a 4-year-old child who came with a history of recurrent respiratory infection. She had a pansystolic murmur at the left sternal border. X-ray chest showed increased pulmonary vascularity. ECG showed left axis and LVH. So let me show the initial echo. Yeah, parasternal long axis view showing a sizable perimembranous VSD with the left to right shunt, and the interventricular gradient measured was 90 millimeters, suggesting there is no significant PAH in this child of 4 years old. This is short axis view. The pulmonary valve is okay. Aortic wall is normal. We're looking to rule out any ductus in this view. There was no ductal flow, as you can see. And now you can we continue to image the perimembranous VSD with the left to right shunt in the short axis view. You can see the VSD defect, sizable one, measured 8 millimeters, left to right shunt, and a PFO flow below that. So these are the two important findings, and based on this, an echo diagnosis of perimembranous subaortic VSD, 8 millimeters with left to right shunt, interventricular gradient of 90, no other associated defects with a PFO. So she was advised VSD closure surgery. She was admitted for surgery. Then we have a pre-operative review echo for every case 1 day before surgery. This time there was nobody else, so I was called in to do this echo. So I said, let me confirm these findings. So this is the short axis view of the left ventricle. Watch the interventricular septum. You get almost a fountain-like continuous flow within the interventricular septum. which was initially mistaken as the same VSD jet. So now you can see it's going from posterior to anterior direction. It's like a fountain jet. Then as you see the aorta, you can see dilated right coronary artery. So you tend to pick up these clues and add one by one some more findings. This is the subcostal modified view, showing the same collaterals now changing the direction from in blue and running towards the pulmonary artery. The next image is again a modified short axis view, where the pulmonary artery is seen. Within the pulmonary artery, you can see a small red flame-like flow where these collaterals are ending in the pulmonary artery. So we have picked up these vital clues in the second echocardiogram just 1 day before surgery, which were all pointing to an ALCAPA, an anomalous left coronary artery from pulmonary artery. So we stopped surgery and advised a cath. This was the revised diagnosis, ALCAPA. This is the LV angio showing the LAO-cranial view showing the VSD. I think there is some problem. This video is not playing. Anyway, what we found is a selective right coronary angio showing big collaterals opacifying the entire left coronary system after some delay, and ultimately the left coronary artery was draining into the pulmonary artery. This was the cath diagnosis, perimembranous VSD and an ALCAPA. So now the plan was revised. Now it is VSD closure plus reimplantation of left coronary artery to aorta. And this is the post-op echo. Now you see the short axis view, ventricular septum doesn't show any collaterals now. Now that the regular coronary flow was restored and the left coronary is now implanted to aorta, you must see no more collaterals. VSD was anyway closed. This is the short axis view of the aorta showing the huge left coronary now implanted from the aorta and a huge septal also. So this is the final result for the child. Now, messages from this case. What are the things that helped in the correct diagnosis? Color interrogation of interventricular septum is very, very important to pick up these coronary collaterals. And the coronary artery imaging should be a part of evaluation of congenital heart disease for various other reasons also. A pre-op echo by a different echocardiographer is probably will be helpful to pick up more findings. And a modified subcostal view for imaging coronary collaterals and a modified basal short axis view for imaging the left coronary draining into the pulmonary artery. These are the things that helped in the correct management of this patient. Otherwise, we would have had a disaster if it was planned only for a VSD closure. Thank you.
So that's a wonderful presentation, Dr. Anjaneyulu. And
Sir, can I make a comment, please?
Yes.
Yeah, please.
Sir, here one thing people have to realize is whenever there is an ALCAPA, there is an ischemia. So there is a hyperglistening endocardium, which is the hallmark of ALCAPA. If that is missed, then they will make it as only VSD or multiple Swiss cheese VSD where the collaterals are seen. So I think every echocardiographer should look at the hyper-echogenic glistening endocardium, dilated left ventricle, and functional mitral regurgitation.
In this case, anyway, she had such an excellent collaterals. There was absolutely no trace of ischemia or a glistening myocardium or even LV dilatation or MR.
So that's a lovely presentation and highlighting the importance of modified or unconventional views. And let's move on to the next presentation is by Dr. J. Cecily Mary from Chennai, and the topic is protean heart, a therapeutic challenge. So I welcome you, Dr. Mary, for your presentation.
Thank
Thank you, sir. Thank you for the opportunities. Respected chairpersons and dear friends, good afternoon to one and all. So I'm presenting here a case of 20-year-old postnatal mother with high-grade fever for 1 week duration. On day 1, when the patient was in a very moribund state with hypotension, the echo revealed a large pericardial effusion with tamponade physiology. Immediately effusion was stamped and the repeat echo was done on the next day, the day 2. We are still able to see mild to moderate pericardial effusion and left pleural effusion with normal LV function. Able to see the increased fibrotic strands in the pericardial cavity. Suspecting this, we thought it could be a tuberculous effusion, but we did send the effusion for analysis, whereas ADO was negative. It was an exudative effusion. So with high-grade fever, this is the short axis view, once again showing normal LV function with we're able to see the effusion still persistent. We did a second drainage, and patient was on the improving trend, but she had high-grade fever. This is day 3. So the third day, on close monitoring, we were able to see a small ball-sized cori vegetation, cori thrombus, which was present in the HL aspect of the PML. So we were wondering, in the presence of fever, what was this? So we suspected whether it could be a vegetation or a thrombus. So vegetation was the first suspicion, because with the high-grade fever in a postnatal mother, so we by then we had the results. Blood culture also was sent. So we started out on higher antibiotics. This is the close-up. Definitely this was not an artifact. There is a small ball size thing was present. So then the day 4, immediately we started on antibiotics. The effusion was drained. We were able to see a constrictive physiology. There was the septal E prime of the septal and the lateral annulus. The lateral annulus E prime was reduced. The hepatic vein flow reversal. Here we are able to see the hepatic vein flow reversal when compared to the forward flow was almost more than 0.8, which is a definitive sign of constriction. So then we had to, in spite of that, we have to put her on steroids also along with higher antibiotics. On day 6 morning, the patient had regional wall motion abnormality. To our shock, we didn't know what to do, and then we put her on the same day. We started her on anticoagulation heparin. The same day evening, when we did this echo, we were immediately able to see a transparent clot-like structure, whether it is a cystic, but in the presence of regional wall motion abnormality, our first thought was definitely a thrombus, and we raised the heparin levels to maintain an adequate APTT, and we were able to still see the small structure over there. Then we thought, okay, it's we are dealing with some other issue. We did a coronary angio also, but the angio was absolutely normal. So this is on regular follow-up. Still, we were able to see the clot getting organized. So we confirmed that this is definitely a clot, and then we are able to see the residual pericardial effusion, but the effusion has now come down. And this is day 10. We were able to see that it was more like a stress cardiomyopathy, where there is contraction of the basal segments, whereas the apical segments were totally, the contraction was very much reduced. In this view, we are able to see the clot also, the clot getting organized now. We are able to see the clot, and this is the clot getting organized. And we are definitely able to see that the apical segments are definitely hypokinetic, whereas the basal segments are okay. So we suspect it could be with the normal coronary angiogram in this patient, could be a stress cardiomyopathy with clot, or initially we thought it a thrombus in the coronary artery causing, but it didn't confine to the regular segments of particular territory. But coronary angio, since it was normal, okay, we thought it could be. So in the same patient, with day-to-day changes from morning till evening, every day, time to time, there were changes. In a postnatal mother, day 1 was pericardial tamponade. There was involvement of pericardium, myocardium, and endocardium. Day 1 was pericardial tamponade drain, then vegetation of thrombus in PML, and day 3 there was a constrictive physiology, and day 6 morning patient had renal wall motion abnormality. The evening itself patient had an LV apical clot. So then we had a series of investigations done. We had rheumatology workup and other things. Lupus anticoagulant came as positive, more than the 99th percentile. And with these evidence, we had to, tuberculosis ADA was negative. We put her on high dose because it was a patient was very sick and moribund. We had to start her on a higher dose of antibiotics, anticoagulants, along with steroids. So on thorough follow-up, we were able to, I'll just show 1 month of follow-up of the same patient. This is the presentation on day 3, whereas at discharge, we are able to see that is only a clot and it has completely resolved. The PML, we are able to see that there is complete resolution. The LV clot on day 6, we are able to see at the time of discharge, the clot has completely disappeared, and we are able to see that there is resolution of renal wall motion abnormality also. This is the A4C. We are able to see the clot formation, gradual clot formation, and finally a complete resolution of the clot. We are able to see that, sorry, 1 second. Yeah, we are able to see that there is a complete resolution of the LV apical clot. So the onset and progress was very turbulent, but gradually when she was treated, we are able to see there is complete resolution of that. And another important thing was there was resolution of constrictive physiology also in this patient. This is the septal annulus, this is the lateral annulus E prime. We are able to clearly see that it has improved, and above all, the hepatic vein flow reversal that is completely resolved in this patient, and we are able to see the difference on day 3 and on discharge. The hepatic vein flow reversal is completely settled. There is one article in JACA 2015 that transient constrictive pericarditis, which is as a result of fluctuating pericardial edema, inflammation, and fibrin deposition, which occurs in 9 to 17% of the cases, which can occur. It is mostly idiopathic, and it can also be precipitated by pericardiotomy, collagen vascular disease, and bacterial pericarditis. So the final message is this patient, young female, in this era of a lot of interventional era, simple echocardiographic evaluation, which was done time to time and day to day, which revealed a pericardial, myocardial, and endocardial involvement in a young postnatal mother, which really posed a diagnostic and therapeutic challenges, which was managed successfully with vigilant echocardiographic monitoring. She had renal failure, she had a stormy course, but she completely resolved, and she went home with a normal LV function and complete resolution of clot. The final diagnosis was a catastrophic antiphospholipid antibody syndrome. This terminology has been described, which occurs in APLAS in 1% of the cases, which is very rare, and there is the sequence of events occurs time to time. But there it has been described multi-organ failure. But this involvement of pericardial, myocardial, and endocardial involvement and complete resolution has been, to our best of our knowledge, first time reported. Thank you, sir. Thank you.
That's a very good presentation, and keeping the time. Yes, Dr. Vijay Lakshmi.
Yeah. Excellent presentation, Cecily. That was great case and very well managed. But in my opinion, even before the thrombus occurred inside the intracardiac, if the streptokinase was given 10,000 units in the intrapericardially, the pericardial fibrosis as well as the intracardiac thrombosis can be prevented. And even that constrictive type of occurring also can be avoided.
Okay.
Thank you.
But would that not increase the risk of bleeding in a postnatal?
No, sir. No, sir. No, sir.
Fair enough. Okay.
Thank
so
you.
that's a learning point, and thank you very much. And now I invite the last speaker of this session, last but not the least, Dr. Rohit Valse from Sri Chitra Institute, and he's going to talk about concomitant VSR and free wall rupture. So I welcome you, and please you can start with the presentation. You are muted, Dr. Valse. Yes.
Yeah. Thank you so much for the kind introduction. My case is a 75-year-old diabetic obese gentleman, case of coronary artery disease, who underwent bypass surgery. Is my slide moving?
No,
yeah,
it is.
Yeah, who underwent bypass surgery in May 2019. And after 6 months following that, he presented with an acute inferior wall STEMI, for which a primary PCI to RCA was done. On day 2 after PCI, he developed decompensated heart failure, for which he was referred to our institute. On presentation, as I said, he was obese. His transthoracic echo window was very poor, and this was the finding on transthoracic echo. It showed a 16 millimeter ventricular septal rupture defect shunting from left to right. And the patient had, and as we know, ventricular septal rupture has a very high mortality, though either with surgical treatment and also with percutaneous intervention ranging from 30% to 88%. The patient was in refractory cardiogenic shock, had severe sepsis and renal dysfunction. So the surgery was deferred, and after a detailed discussion with heart team, he was considered for percutaneous device closure and he was rushed to the cath lab. This is the LV angiogram in LAO view, which shows RV filling through the ventricular septal rupture defect. So 16 millimeter VSR was closed with a 24 muscular VSD device, and after that it was noted that the TE is still showing an additional ventricular rupture defect. And after multiple failed attempts to cross the second defect, we have taken another LV angio, which showed that the shunt has significantly reduced. After this LV angio, we decided to back out, but the next TE image came as a surprise to us, and it showed, along with the additional ventricular defect, there's a ventricular free wall rupture. Presence of such a ventricular free wall rupture without pericardial effusion is very rare. So it was a contained ventricular free wall rupture, which was missed before the procedure. The same can be visualized in 50-degree view. The device can be seen there, additional defect and the free wall rupture. Occurrence of such a contained free wall rupture with ventricular septal rupture is rare, and probably a new MI over an already infarcted myocardium would have led to such dreadful complication. So we had nothing to offer to the patient, and patient was shifted back. He was on IABP support. He continued to deteriorate. The LV function went on worsening. He developed multiple episodes of VTVF and finally succumbed to death. So the lessons learned from this case is, in case of a post-MI ventricular septal rupture, a contained free wall rupture should be carefully looked for. It can be easily missed if not known, and high-risk surgical intervention is probably the only way to salvage in such cases. Thank you.
Yes, Dr. Vijayalakshmi.
So, Rohit, that was an excellent case. And with my experience, just 2D echo is not enough, because IVS is a very curved structure. So in my opinion, if you do 3D or 4D echo, from the RV side and from the LV side. In fact, you can see the rugged ones, and then even the free wall can be seen better with the 3D or the 4D echo. 4D echo is so excellent that in fact on the 2D what we have measured at the 16 millimeter, we got it as 24 millimeter on 4D echo. So I think the 4D probe must be used whenever you are doing such complicated cases before resting. And combination of free wall and interventricular rupture is extremely rare, because free wall rupture itself, they go into cardiogenic shock and then the cardiac tamponade. And this is like a double thamak kind of. Very well managed. Thank you.
And thank you for bringing a case where patient did not do well. You know, we always like to present cases where patients have gone home with smiling face, but it's also important to learn from what should not be done. So that's why I congratulate you for bringing this case where we also learn what not to do or what to do better in such cases. So I think that's about it from this session. If there are any questions, we have 3 or 4 minutes. We can take those questions now. Otherwise, we can conclude.
Dr. Vyas, I would like to ask Dr. Rohit whether the cause for the free wall rupture was the device itself.
No, sir. No, sir. It was initially missed on the 2D echo, and probably that was the reason. So we should have done a detailed transesophageal echo before proceeding with the device closure.
The reason why I'm asking this is because
with the slip pad,
mortality is much higher than a ventricular septal defect rupture, and pericardial effusion is generally a feature of it. Here, because the device was sitting in, possibly that was also interfering with the development of a pericardial tamponade. Which makes me wonder whether the device itself, I'm not suggesting that you created it, please. Just a suggestion that maybe the device itself could have been responsible, because that whole area is necrotic. And there are times when something like a defect could irritate the myocardium and produce a free wall rupture. Thanks a lot. Thank you, Dr. Vyas. That was a wonderful control of the session. I think we'll move on. We are maintaining time. I'm very happy to say that. And I would invite the next session chairperson, Dr. S. Ramakrishna and Dr. Nitin Rao to take over the next session on congenital heart disease.
Yeah, good afternoon. After a very interesting case of very good cases, they're going. Am I audible? Hello, am I audible?
Yes, we can hear you.
Okay. We are going to a very good session on congenital heart disease. It's my pleasure to invite Dr. Nagesha, who will be the first speaker, who will talk on how to assess device suitability of atrial septal defect. And Nagesha is a very good colleague, needs no introduction known. He is the chief cardiologist at Wayne Bush Children's Hospital, and is very good in interventions and in echos, very innovative in echos, and does a lot of work. And he is trained from Chitra, is a very good colleague. It's my pleasure to introduce him. He will talk on assessment of device suitability for atrial septal. Please welcome Nagesha. Okay.
Thank you very much for your kind introduction, Nitin, and it's my great pleasure to be part of this program. I thank Dr. Raghu. He is a senior cardiologist and invited me to give a talk on this, and I would like to express my gratitude to all the organizers of this meeting. Without wasting time, let me actually express my views and our experience of assessment of the ASD assessment for the device closure. So I have certain key issues to discuss. My agenda is going to be to discuss predominantly on the contraindications, criteria, views, suitability, and measurement of the rims. If you look at the atrial septal defect contraindications, ASD with severe pulmonary hypertension cannot be closed. Now people started doing with the fenestration, but it is a very dangerous because the results are not known. Primum atrial septal defect, common ASD, and absent to 2 opposite rims, and sinus venous atrial septal defect, it's almost always associated with PAPVR, cannot be closed with the device. There are different approaches available at this point of time, but still it's all under investigational mode. So if you look at this particular echocardiographic picture of a child, this is a subsified view showing bicaval view. This is the inferior vena cava, superior vena cava, a eustachian valve which is prominent. There is a large fossa ovalis defect. Pulmonary veins you can see as if it is draining into right atrium, and also some of the shunt is going to the inferior vena cava, suggests this a posterior defect, inferior posterior defect. There is an absent IVC rim. This defect cannot be closed by the ASD device, and this is a large sinus venosus defect, and again cannot be closed with the device closure. There are relative contraindications like a deficit inferior posterior rim. Both anterior and posterior rims are small, deficit at 45 degrees. Small mitral rim often unnoticed, often not assessed properly by most, even senior most cardiologists, will be an issue during the device closure. A large ASD with additional or small deficit rims is going to be a challenge for the interventional cardiologist. Important aspects are, when we close the ASDs, we should keep in mind about the age and weight. We don't close less than 3 years unless there is a different indication, less than 10 kilograms. And if you have any moderate ASD with severe PAH, that is not due to ASD. You all should remember that is due to an associated idiopathic pulmonary hypertension and the presence of myocardial disease, conduction abnormalities, partial anomalous pulmonary venous return, and also mitral regurgitation are going to be an important relative contraindications assessment issues as an integral part. If you look at the anatomy of the ASD, we should know the morphology anatomy, how echocardiogram at apical view, and also in short axis view, and in subsified view, we are going to project the intra-atrial septum. So if you look at this, this is all going to be from the right atrial side, tricuspid wall, posterior, you can see coronary sinus, this is the fossa, limbus, superior vena cava, inferior vena cava, and torus aorticus. So in transthoracic echocardiogram in children, we can meticulously assess a 4-chamber view. You can see the defect here, and in short axis view, you can see the anterior defect and the posterior rim here. Whereas in subsified, you can see both IVC rim, SVC rim, beautifully seen SVC. This is absolutely suitable for the device closure. So when you are evaluating the subsified approach, the interatrial septum from the posterior to anterior, you should sweep from posterior to anterior. You will see the inferior vena cava, hepatic veins here, eustachian valve, and right upper pulmonary vein. Then you can see the SVC, a mid-atrial septum here, and also anterior atrial septum, anterior portion here, aorta. This is how you evaluate the interatrial septum from the subsified approach. Now look at this case example here. There is a atrial rim. This is the AV valve rim, or you can not AV valve rim. This is the IVC rim and SVC rim. It's both are malaligned like this. Measurement of this kind of interatrial septum is quite challenging. So this information you will get only in subsified sagittal cut section. Subsified coronal view also is very important in terms of the assessment of the defect size. So when you are assessing clearly, you should have a kind of nomenclature. Earlier, people attempted to call superior posterior, superior inferior posterior, anterior rims, all those things cause a lot of serious confusion. If you look at the 3D picture here, the IVC comes here, SVC here, and torus aorticus. So first, Professor Savitri Srivatsava and Dr. Radhakrishnan, senior and very close friend of most of us, did some nomenclature based on the surrounding structures. So when you have aorta here, we can call it as a retroaortic rim. When you have a defect which is close to the atrial or pulmonary vein, that is called as a pulmonary vein rim or atrial rim. This is going to be AV valve rim or mitral rim from left atrial side. inferior posterior, posterior and inferior posterior defects are called. Nothing but IVC rim here. So when you are assessing the rims, it's mandatory to have the proper assessment. Make sure the rims are thick in size, thick in strength, and also you should be more than 5 millimeters at least. Senior or established interventional programs or experienced hands, they may actually do even in lesser than 5 millimeter deficit rims also will be able to accommodate the device. But it's all based on the individual institutional experience of that particular individual. So this is atrial rim, then AV wall rim, then retroaortic rim, then SVC rim, IVC rim or inferior posterior rim. So when you are assessing the rims, it is mandatory to see how much of extent that rim is actually absent or deficient. So you have to go all views posteriorly, mid and anteriorly, or inferior, mid and superiorly when you are doing a transesophageal echocardiogram. So I am going to show you that how we actually assess in case of with the transesophageal echocardiogram. So when you are doing a 4-chamber view in transthoracic echocardiogram, that is going to be 0 degrees, and when you are doing a 45 degrees, that is equivalent of a short axis view. When you are doing a bicaval view, that is between 90 to 120 degrees, that is going to be a transesophageal equivalent of 90 to 100 subsified bicaval view. There are additional views like a retroflexion 70 degrees, first described by Amruta group, Dr. Krishna Kumar and all. In case of a deficient inferior posterior rim, you go to the transgastric and retroflex the transesophageal probe, then you will be able to assess that. I am going to show you a couple of examples here. Now you see this is the transesophageal echocardiogram showed in 0 degrees, a good AV wall rim here, mitral rim, whereas atrial rim is somewhat deficient here. So that's how in transthoracic echocardiogram. So you go 4-chamber inferior cut and mid cut here. You will see the aorta little bit, even in 0 degrees. So this all going to get information that the atrial rim is good here, the pulmonary venous rim, whereas here you can see in 0 degrees, retroaortic rim is absent. Whereas 45 degrees, where you can see the posterior and anterior, here retroaortic rim is deficient, whereas the posterior rim is very floppy. So similarly, you can see in bicaval view here, you have a good SVC rim, good IVC rim here, and for the it is absolutely suitable for device closure. Whereas here you can see the posterior rim is absent, and this is not suitable for the device closure. What I told you, retroflexion or going to the 90 to 120 degrees, you will see the torus aorticus here. You will see the anterior part in that particular view. Whereas the retroflexion, this is the small rim which is present, which is not seen in 90 degrees, but when you go transgastric, you will be able to see that. So to summarize this particular information, 0 degrees is nothing but a 4-chamber view. You will see mitral rim, pulmonary venous rim, whereas 0 degrees with superior pull, you will see the aorta and pulmonary vein very nicely. Whereas short axis, you will see anterior posterior rim, retroaortic rim, and posterior rim. Whereas 90 to 100 degrees, you will get a bicaval view and you can study it very nicely. 3D is informative to some extent, but I am not going to recommend that because how much of gain you put, based on that, your 3D image will come. But it will get overall idea that whether this is really good case to do or not. Moderate defects, you will get wonderful pictures, whereas the large deficit rims, you will have some kind of inadequate information in 3D. So here you can see the example of a 0 degree atrial rim is absent and SVC rim is absent. Whereas atrial rim in the 45 degrees, you can see both the rims are absent. I won't say it is the posterior rim is absent, but it is a deficit. This is a very, very dangerous case to do. Only experienced people can do. Here you can see totally absent septum on 2 orthogonal two rims, that is retroaortic rim and posterior rim, this is going to be contraindicator for the device closure. Whereas here you can see a floppy rim here, you should really take a good sizing in this. If you do in 90 degrees, the same case, you have absent SVC rim here, and this is going to be again an issue. Whereas 70 degrees retroflexion, you can barely see a small thin line is seen. So only experienced people can do. Here in 45 degrees, here in bicaval view, 90 degrees here, you can see totally absent posterior rim here. This is absolute contraindication according to me for the device closure. Whereas SVC rim deficit is rarely seen. You can look at it from right atrial side, rim appears small. But if you see from left atrial side, you have SVC rim extending up to the pulmonary vein. So I would be happy to close that. I would like to know the timing. What time? Can you display the time, please?
So timer is finished at 12, sir.
Yeah. So you have 12 minutes?
Yes, sir.
You're just about, okay.
I'm going to show you the last part in 1 minute. So this is how in floppy rims, you can see the floppy rim here, where to measure is an issue. So we had to put the balloon here and then do sizing here. So when you do sizing, then you will see really whether it is suitable. ECG will give information in a prolonged PR interval, and you look at this last case example where mitral rim is absent. We attempted and we could not close this. So multiple defects is an issue, but individual approach is very important whether to close or not. We have a couple of examples here. You can see that multiple defects are closed. I'll go to the last slide called summary. So meticulous evaluation by both transthoracic and transesophageal evaluation of atrial septum is crucial for the suitability and sizing. Deficit rims should be clearly assessed for the appropriate method, and you should have complete idea before we are going to do what size of the device, what method we are going to do, whether we are going to park in the pulmonary vein or balloon assisted technique. Floppy rims should be considered, and we should not take the measurements of the echo alone. We should put a balloon and then see the staff flow technique. Thank you very much for your kind attention.
Yeah, thank you so much, Nageshwara. Very lucid and erudite presentation. I'd just like to say we have 12 minutes for speakers and 3 minutes for question answers. Maybe if we can type the question in the Q&A, we can take the question at the end of the session. Ramkrishna would like to add?
I think excellent summarization of what we routinely do in lab. The most important, I want, for the sake of audience, I wanted to ask you 2 questions. In which cases in an adult patient with ASD, you would tend to not do it under transesophageal guidance? Like, or should transesophageal echo is a must in all patients with ASD assessment?
So transesophageal echocardiogram is a must in all cases of adults. Whereas in children who has got a good subsuphied window, I think we can only do transthoracic echo. If you don't have subsuphied window, and if there is a deficient rims, especially posterior rim, IVC rim, I think even in children you should do transesophageal echo. Whenever you have doubt about the multiple ASTs and also floppy septum, we should definitely do transesophageal echo irrespective of the age group.
Thank you, sir. And about the utility of 3D echo, do you consider it in multiple ASDs? Like, when do you consider 3D echo as an advantage? Like,
I think you actually gave a leading answer for that. I do 3D echoes, but 3D echo is going to be a cosmetic type of echocardiogram we get most of the times in case of moderate AST. But as you said rightly, I use predominantly 3D echocardiogram when we are putting 2 devices. When you put 2 devices, you will get absolute idea how the device area of one defect and another effect is going to encroach and see the surrounding structures. I did not emphasize that point during my talk. Ramakrishna, I appreciate you and thank you. 2D echo is going to be useful in case of a multiple atrial septal defect if the interventionist decides to close those defects.
Thank you, Dr. Nitin. I think we should move on. Wonderful talk, Dr. Nageshwara.
Very well.
Thank you very much.
Yeah, Ramakrishna.
I think we'll move to the next talk, which is by Dr. Munesh Tomar. It's on diastolic flow reversal in descending aorta. Yes, ma'am, your slides are seen now, ma'am. You can go ahead.
Okay, so I am visible and audible.
Very well.
Thank you. Thank you, Echo India 2020, for inviting me and giving the opportunity. Without wasting my time and congratulating Nageshwar Rao for a nice presentation, I'm moving towards my presentation, that is diastolic flow reversal in aorta. So when we talk about the diastolic flow reversal, we mainly think about the congenital wise PTA and in grown up about the aortic recession. So these are the most common lesions which come to your mind when we think about the diastolic flow. But there is a lot into the heart other than these two common lesions. So starting with a simple case, that is 11-month-old baby weighing with failure to thrive, features of CHF and PH, clinically large PTA was there, X-ray, ECG, everything there was large PTA. And on echo, you can see this is 4-chamber view showing dilated left heart, modified ductal view showing a large ductus arteriosus with left to right shunt and in aorta. With color flow mapping, we can see a normal aortic arch with reversal of flow. And very important to note, when we talk about the diastolic flow reversal, here, like on M mode with color flow mapping, there is integrate flow in systole, then in diastole. In lower part, there is return flow, and in the upper part, even in diastole, you are having a flow because the still is occurring at the level of ductus arteriosus. So that is very typical of PDA, in contrast to an other lesion, which I am going to show you. This is same view with severe aortic regurgitation, and you can see the pan-diastolic flow reversal going into the aortic arch in proximal aorta because your runoff is at the level of aortic valve. And here it is a pan-diastolic flow reversal, and here was an integrate flow up to isthmus with PDA, and this is all reversed in whole diastole into the aorta. So these are the common thing, but when there is flow reversal, no AR or no PDA, we have to search for the more lesions. The important thing is patent ductus arteriosus. Aortopulmonary window. Aortopulmonary window is a diagnosis of suspicion. You have to find clinically CHF, PH, dilated left heart, flow reversal in aorta, then you need to search for the aortopulmonary window. Sometimes it is very easily seen, sometimes it is very high window, and you need to find that particular area where you are, the AP window is situated. So this is important lesion which needs early surgery within the first few weeks of life. Then branch pulmonary artery from ascending aorta. So again, if you look at this parasternal short axis view, this is aorta, this is the branch pulmonary artery. So very, very clearly you can miss this. You can take it main pulmonary artery branching into two, but look carefully, there is a communication between ascending aorta and the right pulmonary artery, and this is on the color flow mapping. So MPA is continuing into LPA, while the RPA is coming from the ascending aorta. Again, here your one lung is with systemic pressure, another lung is at lower pressure. So a very significant damage of one lung, which is arising from the ascending aorta, very fast damage happens. So we need to correct early. As for the AP window, even for RPA from ascending aorta, earlier intervention you need to do, that is the surgical intervention only. Truncus arteriosus, it's a very easily picked up lesion, so nothing to discuss in that. You get a large VSD, common trunk, from where you will see pulmonary artery arising. Obviously, it is again, you will find flow reversal in aorta because flow is stealing into the pulmonary circulation. It is arising from common truncus. Then this is the coronary fistula. If coronary fistula is large, you will find it will again lead to the large shunt. That fistula can open into any chamber from the right or left coronary artery. So this is modified parasternal short axis view. This is hugely dilated left coronary artery, circumflex artery, giving rise to fistula into the right ventricular inflow. So it can open into left side, right side, and depending on the location your shunt will be, depending on the size your quantity of shunt will be, and has to be closed. Like for the PD, you need to go for the device with the coil closer of the fistula. This is an interesting case. A 1.5-month-old baby came with the CHF for us. And if you look at the parasternal long axis view, this is an aorta, this is aortic valve. Close to aortic valve, there is sort of extra channel is seen here. And the regurgitant flow is coming from that. That is aorta to LV tunnel. So the good thing here is you need to just close this tunnel. It is again a surgical intervention because child is small. You can't wait in these patients. But closure is a one-time thing because your aortic valve is normal here. And this is RSOV, all of adult colic very commonly see rupture sinus of Valsalva. Aneurysm, again, this can open into any chamber, left or right side. Depending on that, your shunt flow will be there. But ascending flow reversal up to ascending aorta, you will find in all these cases of rupture sinus of Valsalva. And they need closure early, mainly by surgical. In very selective cases, we go for the device closure of these RSOV. This is a case of VSD, which ideally this echo should not happen. So there is a VSD, there is a right coronary cusp being prolapsed into that and subaortic membrane. This subaortic membrane is just holding the right coronary cusp. So a right coronary cusp is not getting the cooperation is not happening with the left coronary cusp, leading to severe aortic regurgitation. And if you look at the jet of the aortic regurgitation, this is so oblique. You can't get vena contracta, you can't get pressure half time, you will just get dilated LV with flow, severe pan-diastolic flow reversal in aorta. So this obviously has to intervene early. This complication should be prevented. But it happened, you need to go for early surgery, valve repair plus minus valve replacement, because the late the child appear, the result of surgery will be poorer. And look for the combination of lesion. If you find one explanation for your flow reversal, you can't just sit with that. So a complete sequential approach is very important in all patients of congenital heart defects. So here it is a PTA, usual PTA with left to right shunt with a small diastolic gradient. So I can't leave here, but if you look carefully, this is RP from ascending aorta from same child. And this was a very old child, 14-year-old came to us with PTA. Obviously, we had to leave his right lung isenmangerize and did PTA closure of the left lung. So like in previous talk, it was told you need to check sequentially each and every segment of the heart before concluding your echo report. But there is more to that for the flow reversal. You don't find anything intracardiac, you have to find something outside the heart. You can't leave the flow reversal in aorta just that it is there, my echo is normal. So this is the cranial ultrasound where you are seeing a large cavity with AV fistula, basically vein of Gallen malformation. And these babies, even in fetal ultrasound, fetal echo, you can pick these things. These can lead to the fetal or the neonatal heart failure. Very early intervention, that is a coil closure is needed for that. And then very fast the brain damage happen and you lose these kids. It is a very high risk intervention, but still that is the only hope we have. This is a 2-month-old child. You can see how vigorous the heart is, came with CHF, and I could not find anything intracardiac. LALV dilated, there is tachycardia, tachypnea, X-ray-wise, there was cardiomegaly, there was no AP window, no PDA. I was keep on searching, I could not find anything. Arch was normal except the flow reversal. And when I followed, the left artery was normal, left subclavian artery was normal. Into the innominate artery, very distally, I found a fistula. Connecting to the systemic vein that was leading to the cardiac failure in this child. So suspicion on echo is very important. We can't just leave at this point that I can't find anything. So suspicion was there, then it was confirmed by the CT and it was device closure was done in this child. And the right VT shunt, obviously. This is a post-op patient for VSD pulmonary atresia. So this is the VT shunt. If you find a pan-diastolic flow reversal in VT shunt, that shows your shunt flow is too much. So in post-op period, it will lead to the sick ICU stay. And if it is pan-diastolic, you sometimes need to go to revise your VT shunt because too much flow is happening into the lungs in these babies. So to summarize, structural defects, a long list. PGA, AP window, PA from ascending aorta, truncus arteriosus, congenital aorta LV tunnel, RSOV, other causes of aortic regurgitation, a long list you all know. Vascular malformation are very important here because these are all our intracardiac things which you see on echocardiography. But outside the heart, we have two things. So like vein of Gallen malformation, branch the AV fistula, systemic AV fistula, and the post-PT shunt. Other than a structural heart defect, there is list still continues. So that is aortic. It's a very good article in 2013 Hypertension Journal. They showed aortic stiffness in systemic arterial hypertension leading to early diastolic flow reversal as a cause of cerebral vascular accidents. So that article is worth reading. So aortic stiffness, one is with the systemic arterial hypertension, which is reported and known in adult patient, one in pediatric and in other ICU sick patients. It is a low cardiac output leading to narrow pulse pressure. High diastolic pressure will also lead to early diastolic flow reversal. Very frequently we see flow reversal in obstructive TAV. Severe PH, it is a right heart dependent circulation. RV failure lead to your flow reversal. Dilated cardiomyopathy with Kawasaki. With COVID cardiomyopathy, we are seeing flow reversal, but it is an early diastole. This is very important to note this. Means patient is definitely in low cardiac output stage. And in low vascular resistance like anemia, thiamine, hyperthyroidism, liver cirrhosis. In this condition, I could not find any explanation for the flow reversal, but probably it is vascular dilatation, it is high volume, leading to altered hemodynamics, flow dynamics in these patients. And it is mainly early to mid diastole. So this is a 4-chamber heart of patient with obstructive TAVC, hugely dilated RARV, TR, severe PH, and this is my aortic color Doppler flow mapping. You can see early diastolic flow reversal in this patient. This is a patient with dilated cardiomyopathy with non-compaction. Mild mitral registration was there, and you can see again there is diastolic flow reversal. And this is color M mode with color Doppler, again early diastolic flow reversal. And this is the pattern in these sick patients we find. So systolic antegrade flow, diastolic reversal, then again you get a small systolic antegrade flow. So this is the explanation for that. This type of pattern you get in this sick patient that points towards the high diastolic pressure leading to the aortic runoff in these patients. And obviously that one-way convey in sick patients, poor ICU outcome, high risk, poor prognostic factor when we find diastolic flow reversal, especially at the level of abdominal diaphragm in post-op cardiac patients. This is just, you can see as a quiz. So this is ascent aortic arch view, very small ascending aorta, and the flow reversal. It is opposite to PDA and left to right shunt. So here my suprasystemic pulmonary ductus arteriosus filling the ascending aorta, so retrograde flow. So diastolic flow reversal is still there, but it is the systole and diastole. And systole, basically, the flow is going into the ascending circulation by the suprasystemic ductus arteriosus. So this is totally different from the whatever you are talking in these. So these are the few differences. Other than they are aortic registration where the explanation for flow reversal in diastole on echo is being given. Thank you for your kind attention.
Thank you, Dr. Manish. Very lucid, very nice one. Thank you for good images, especially the LV, aorta LV tunnel. That was very good. We rarely see that. Very nice. And for shortage of time, we'll probably move on to the next. Thank you so much, Dr. Manish.
Thank you. Thank you.
Our next speaker is Dr. Saji Philip, who's going to talk on VSD, what I need to see on it. Classification of VSD and what I need to see. Dr. Saji?
Yeah, am I audible?
Yes, please.
At the outset, let me thank the organizers for giving this opportunity to present VSD current classification and what all I should see by echo. I don't think I can finish it off within 12 minutes, but I will try my level best. I know all of you liked my virtual background. So the VSD, even though VSD is the most common congenital cardiac malformation, around 15 to 20%, there is no consensus on how to describe and categorize these lesions. But the key to understanding the definitions, to appreciate the defect or intraventricular communication, if you want to define the border, we should appreciate the VSD from the morphological RV side. This is the morphological RV side. Wherever the defect comes, Accordingly, the definition will come. If the defects in the anteriorly, if you see it's a marginal muscular VSD, central muscular VSD. If it is apical muscular VSD, if it is very near the outlet of the pulmonary valve, we call it as doubly committed or subpulmonary VSD. That is the old term. Now the defect just below the aorta, it's an outlet subaortic VSD. Any VSD is inlet towards the inlet area of the tricuspid valve, it is inlet VSD. So it formed from three sources: muscular septum, and the outlet portion from the conotruncal septum, and the inlet portion is from the endocardial cushion. The present classification, the endocardial cushion defect is not included, because once the crux forms, then only you can define the VSD borders. If the crux is absent, AV continuation is common, and so that the endocardial cushion defect will come. So the present classification, we excluded the endocardial cushion. Now this is the classification of the ventricular septal defect by Lopez et al. In 2018 by Annal of Thoracic Surgery. And if you see the classification, it is really cumbersome. I think it is really for the operative finding, or if it is for the cardiac thoracic surgeon in detail, I don't know. I don't want to make the delegates to make a lot of confusion, lot of date-like numbers are there. That is nothing but ICD code. So I made it a very simple way. From that chart, it is, remember, perimembranous central VSD, second inlet VSD without a common AV junction, third is a trabecular muscular VSD, that is septal, apical, multiple. Wherever it comes, they put it as trabecular muscular. But in olden times, we put the apical muscular VSD as put usually as a trabecular. So, but all the type of VSD muscular, they defined as trabecular muscular VSD. Then the fourth is outlet VSD. So here you cannot visualize the subpulmonary VSD, but that is replaced by the doubly committed. That is the real term. Doubly committed juxtaarterial without malalignment as considered as subpulmonary VSD. So this is the central perimembranous defect. As I said, the view is from the morphological RV. This is the central muscular VSD that is usually behind the septal leaflet or the tricuspid valve. This is the androseptal commissure here. And the VSD is almost in whereas in the inlet VSD, the VSD will be inflow to the inflow area of the tricuspid valve. Here, the defect will be below the androseptal commissure of the tricuspid valve. And the third one is the trabecular muscular VSD, wherever I already explained all these different types of defect, wherever the location as per that, you can define trabecular muscular VSD. Sometimes the inlet portion is opening near the behind the tricuspid valve, but at the same time extending to the muscular portion. So this is in that's such VSD called inlet muscular VSD. So the two anatomical descriptions of VSD were made by Richard Panbarag and Robert Anderson. We know very well, and Anderson classification is more and more simplified. So I suggest that the Anderson classification is the simplest one for the people, those who are in the echo lab. Don't be confused with the detailed cumbersome chart. You think the perimembranous muscular and doubly committed juxta-arterial. That is nothing but subpulmonary VSD. So this is a morphological specimen I dissected, and these are the portion of the trabecular area Any defect in the nearby that we call muscular VSD. Any defect near the membranous portion is perimembranous. This is the tricuspid valve. The defect behind the tricuspid valve we can define as a inlet type, and any defect near the pulmonary artery, it is a doubly committed. This is 22 weeks of fetal cardiac specimen. This I opened, sorry, this morphological LV, I opened it from the LV side, and very nicely we can see a subaortic VSD, and you can see the cusp of the aortic valve. And here the aorta, you can see here, then this is the pulmonary artery, and the defect is just below the pulmonary artery. That is nothing but doubly committed VSD. So what all you need to know: one, clinical observation, ideal views for evaluation, anatomical types of VSD I already mentioned, how to assess their severity, and intervention when to do. So clinical observation is very important. I know all you people are in the echo lab with the probe of the echo machine, rarely carrying the stethoscope. Before you putting the probe on the chest, you just auscultate and hear the murmur. If you are hearing a pansystolic murmur, definitely you have an idea. This could be a VSD. So here, the observation is very important. Before you putting your probe on the chest, look at the chest. It's very important, the observation. Mama, did you bring the chest X-ray? Okay, let me see. You see the X-ray, cardiomegaly, increased bronchovascular marking. So clinically, you should look for the signs and symptoms of heart failure. That will be really helpful. Along with your report, you send a note that if you are not started the decongestive measure, could you please start a decongestive measure? So that is very important thing. Look at this chest movement. Definitely, this is a 5-month-old infant with a difficulty in feeding, tachypnea, tachycardia, and echo shows RCC prolapse with the AR. Here you can see a fish hook like right coronary cusp and almost moving into the RV side. If you wait for some more time, you can see the deformation of the RCC, and it can produce more AR, bigot AR. We should not allow such children to go ahead further and later to replace the aortic valve. So the assessment of the severity of the VSD by size or shunt is very simple. Less than 5 mm or less than 50% of the aortic annulus is small. Moderate 5 to 10 mm, 50 to 75% of AO annulus. Large is more than 10 or more than AO annulus size is 75%. In terms of Q/P/Qs ratio, you can take the screenshot. This is the calculation. Now all the new equipments have automatic calculation. Less than 1.5 QP is small, 1.5 to 2 is moderate, and more than 2 is large and is indicated for surgery. I say if it is 7 mm in a neonate, I say it's a moderate to large because the size of the baby also important. So the next is the view. What are the views you take? Sax view, plaques view, apical four-chamber view, and subcostal view. I am not going to describe all the views, but I will mix it up for a basic idea for the delegates who are here. The Sax view, the time clock concept between 9 and 12. You see the color flow shunting, it is between 9 and 10 o'clock. Here, another one, 11 to 12 o'clock, this is nothing but perimembranous VSD. And if you are seeing a defect in the 2 o'clock position or 12 o'clock position, this is nothing but previously we say subpulmonary, but it is the correct term is doubly committed VSD. And if you go a little high Sax view, very clear-cut RPA and LPA bifurcation, PA size, you can make it out. Here, you can see a very large VSD in the short axis view at the aortic valve level. Corner septum is deviated towards the RVOT. This may be, you may add that anterior malalignment VSD. Here, the apical 5-chamber view showing a VSD, that is a PM VSD. And the apical 4-chamber view, if you see a VSD, that is nothing but an inlet VSD. So the observation power has to be improved in each cases. So here you can make out that the LALV is enlarged. That is the first impression you should have. What are the things you should look for VSD? If you heard a pansystolic murmur, it is a VSD. If you hear a continuous murmur, it is PDA. If you're hearing a systolic murmur in the interscapula area, it is COA. If it is a Al-Kappa at the short axis view, if you see a coronary artery anomaly, or if you see a ECG with a Q wave in one anavial, it is Al-Kappa. If the EF is much reduced, you can diagnose a DCM. So look at the defect where here you can see both red and blue. That is a bidirectional shunt. So that is very important thing. Before you sending to the surgeon, you have to clarify the pH part. Here you can see the overriding. It's a 50%. Of course, with the small PA, you can say it is a TOF. If more than 50% overriding, you can say DORV. If it is less than 50%, anterior malalignment VSD. Here, again, I am showing the fish hook appearance of the right coronary cusp. Very careful. And you see the jet just below the right coronary cusp. That is a very important thing. If you are seeing a AR, definitely that is for the indication for surgery. Here, again, most of the time, basal and mid part of the IVS only you people will see in the parasternal long axis view. But keep on you move either to the RVOT level or towards the right shoulder, then you can see the apical portion of the IVS also, so that you can find out the muscular apical muscular VSD. Most of the time, if you are seeing a routine view, you may miss the muscular VSD, but whereas if you auscultate and do the echo, definitely you will search for the muscular VSD. Here, again, you see that is a...
Dr. Saji, you have to wind up, like the time is up.
Yes,
Sorry.
the last slide. And you see that there is a subaortic ridge and a deformed coronary cusp. Even on the short axis level, you can see. Even here, RCC is really deformed and is pushing to the RV. So again, the Doppler will help you, hyperkinetic pH, and you can measure the mean PA. And this is the definite indication for VSD closure, overriding of aorta, moderate to large VSD with a ridge, and RCC prolapse with the AR. And Dr. Nagesh Rao is here. He invented a wonderful device. Even for aneurysmal transformation, we can close it with the device. So thank you once again.
Thank you, Dr. Saji, for covering all aspects about VSD in 12 minutes time, which is a big challenge, I think. For sake of time, we will move to the next talk. We want to know in 12 minutes how much we can know about tetralogy, all the information that surgeons need from echocardiography. Dr. Vijayalakshmi ma'am, please.
Can you speak the slide?
Yes, ma'am. Yes, ma'am.
Go ahead.
Yes, sure.
Okay. Good afternoon, everybody. I thank Dr. Raghu and all the organizers of this Echo India 2020. It's my pleasure to speak about what I can get information from Echo. Slides are not moving. The echo technology has increased by leaps and bounds. And today, literally, it has replaced the catheterization in many of the conditions, including tetralogy, except few exceptions. So echo can detect all the 4 anatomical abnormalities That is the cardinal features that we see in the large mal-aligned non-restrictive VSD with the bidirectional shunt, then right ventricular outflow tract obstruction, dextroposition of the large aorta, which is overriding, and also the right ventricular hypertrophy. All these 4 features are very well detected by the echocardiography. But anatomic spectrum is diverse. It includes variants of like tetralogy with pulmonary atresia, and also top with absent pulmonary valve and syndrome, and also absent RPA and LPA, and also the coronary anomalies in these. So they require something more than echo. So here, when you look at the parasternal long axis view, we can see that the mitral aortic continuity is there, large overriding aorta, and then, you know, in the apical 4th chamber, we can see the bidirectional shunt with both RV and LV pumping into the overriding aorta. And making the diagnosis of tetralogy is not a difficult thing at all. But the difficulty comes where there is infundibular, valvar, and the supravalvar stenosis, and that becomes very difficult to make out, especially when there is a branch stenosis. And here you can see that we can make out the infundibular stenosis and the valvar stenosis, but how much each one is contributing becomes difficult because our cursor will go across. So probably the first portion is the infundibular and the next one is the valvar. So whatever it is not as accurate as the catheterization, where the pullback tracing, we can make out the supravalvar, valvar, and the infundibular stenosis. Unlike the catheterization, which is a gold standard in the echo, it is difficult to make out how much the valvar stenosis is there, because in some subset of patients where we would like to the balloon dilatation, we have to assess how much the valvar stenosis is there. And also when there is a large engorged coronary sinus, which indicates the LSVC draining into that requires the separate cannulation, and that also can be information can be given to the surgeon. In fact, we know that there is a non-restrictive VSD always in tetralogy, and we don't get the aortic regurgitation, especially when there is even in the older people. But in some subset of patients, there can be a restrictive VSD because of the tissue growth, and because it is a restrictive VSD and Venturi effect, and you can clearly see that there is a prolapse of the coronary cusp. And this also can be made out by the echocardiography when there is a suprasystemic RV pressure in very rare conditions of tetralogy of Fallot. Coronary arterial anomalies are extremely important for the surgeon, because we have to give the roadmap to them. And here you can clearly see how the right coronary artery is seen and the left coronary artery is seen. But the coronary artery anomalies are seen in about 4 to 12% of the patients, and especially coronary artery across the RVOT is very important, because the surgeon, while doing the infundibulectomy, inadvertently, if the coronary artery is cut, it can be fatal. This is courtesy Dr. L. Srinivas. Here you can see that the single coronary ostia is giving rise to the RCA as well as the LCA, and the LAD can be traced to some extent. But how much it is going across becomes very difficult to make out unless we do either the angiogram or sometimes we have to do the CT. The coronary arteries can be traced to some extent, but in the grown-up children, however, it is very difficult. So intraoperative evaluation of the coronary artery is imperative to avoid the complication during the surgery. So this is the CT where the reconstructed picture, you can see that right coronary artery is arising from the left coronary artery, and then it is going across the RVOT. So this is also one of the rare conditions. Normally we think that the LAD goes across, but the right coronary artery or even the conal branch can go across. So here you can see that the volume rendered surface reconstruction shows a prominent conal branch of the right coronary artery going across the RVOT. So varieties of them, and here you can see that the RVOT is crossed by the LAD. whether it is LAD, coronal artery, or the right coronary, or a single, it becomes very difficult. And since the fatality is more, we have to go for the precise diagnosis. So importance of knowing the coronary anomaly is presence of major coronary artery located in the infundibular region, and awareness of the coronary anomaly helps in deciding the time and the type of the operative method, and angiographic or CT angio diagnosis of anomalous coronary artery in tetralogy of Fallot is very important to avoid the unnecessary mortality. Now, moving on to the pulmonary atresia, where pulmonary artery is, pulmonary valve is atretic, and then whether we have confluent or non-confluent pulmonary arteries can be made out. And here you can see that there is a total pulmonary atresia, no flow is at all, main pulmonary artery is not there, but the branch pulmonary arteries are confluent. And many a times they'll have a vertical duct supplying to the pulmonary arteries, and that also can be made out from the suprasternal or the high ductal view. We can make out the vertical duct also in these cases. And we can see the multiple collaterals on echo. This is one of the cases from Dr. Srinivas, and the continuous Doppler will be there. But however, though we can make out the multiple major pulmonary artery aortopulmonary collaterals, we would not be able to make out whether how big they are and what is the inside pressure, and those things have to be made out. So gone are the days when we used to do the autopsy to find out the pulmonary atresia or the absent pulmonary valve syndrome. But today the echo is so good, and we can suspect this on the X-ray itself. Instead of the empty conus, if we have a full one and aneurysmally dilated main pulmonary artery, we must suspect the absent pulmonary valve syndrome. And here you can see that the annulus is very, very narrow, and that causes the stenosis. And the post-stenotic dilatation gives rise to the large pulmonary arteries as well as the main pulmonary artery. In a normal tetralogy, infundibulum is narrow, but here infundibular portion also is aneurysmally dilated. So this is an exception where there is an absent pulmonary flow. So here you can see that the narrow annulus causes the stenosis, and there is a free regurgitation causing the pulmonary stenosis as well as the pulmonary regurgitation in the Doppler as well as the color flow. And absent pulmonary valve can be associated with the absent left pulmonary artery. Here you can see that it is blunt, and they can also be absent right pulmonary artery. So there can be what we call as a Dubuque syndrome. In the Dubuque syndrome, we can see that in the X-ray there is a left hemithorax is very small, and then there is a hyperlucent left lung. And when we do the echo, we can see that the whole of the pulmonary flow, it goes into the right pulmonary artery, and there is no left pulmonary artery. So this is called as the Dubuque syndrome, and this information has to be given to the surgeon because the method of surgery will be entirely different. And then we can have the peripheral pulmonary artery stenosis, and here you can see that there is this is an absent right pulmonary artery here. The arrow is showing that nothing is flowing into the right pulmonary artery, and this is also extremely rare and less than 1.2%. We can have the branch stenosis, the right pulmonary artery stenosis can be there, or the left pulmonary artery stenosis. And if this is not explained to the surgeon, the post-operative period will be high, or we can do the hybrid where we dilate the pulmonary artery or do the stenting before sending for the surgery. And for that, you can see that an excellent 4D echo, you can see literally like a histopathology, how narrow and long tubular stenosis is there, and that can be made out on the 4D echo. And the 4D echo gives to make the decision how long and how big the stent has to be taken. So this is the way we have to assess the peripheral pulmonary artery stenosis, and echo gives an excellent picture of that. Now coming to the post-operative, the BT shunt, whether it is functioning or not functioning, will have a murmur, continuous murmur, and then we can see the continuous flow across. But however, though the echo tells the BT shunt is functioning, we cannot make out whether the RPA and LPA, whether they are stenosed and how severe is the stenosis. And because of this, we have to go for the CT angio or the MR. And here we can see that this is the BT shunt, and then there is a tight right pulmonary artery stenosis, branch stenosis, LPA stenosis, and these are very important before taking for the intracardiac repair. And hence the echo is not enough, and we have to go for either 3D or the reconstruction, CT reconstruction, where you can see that only the collaterals, aortopulmonary collaterals are supplying to the pulmonary arteries. And especially for the unifocalization to know, it is very important that we have to know the collaterals, the types and the pressure. Not only that, the post-operative complications of tetralogy can be made out very well by echo. And here you can see that this patient has come with the congestive cardiac failure after the surgical correction, and which is extremely rare in tetralogy. And here you can see that the part of the aorta which was like overriding the septum, that this is the patch which has not covered the aorta, and as a result the aortic regurgitation is occurring into the right ventricle, and that is extremely rare complication, and that also can be made out. And the post-operatively the patient came with the vegetation, and here you can see that the vegetation also was causing obstruction. And with this we can say that measuring the RPA and LPA and main pulmonary artery and aorta is very important to know the Z-score. And here we have to measure the RPA, LPA in the ductal view, and the Z-score has to be used for correct assessment. And web-based calculator is available to make the Z-score calculation. So to conclude, echocardiography can confirm the diagnosis of tetralogy of Fallot by demonstrating large malaligned VSD, overriding aorta, infundibulous stenosis, RVH, but coronary anomalies can be suspected by echocardiography, but it should be confirmed by the CT angio or the angiogram. The collaterals and the vertical duct can be detected by echo, but for unifocalization, the type of collaterals pressure cannot be made out by echo. Now, CT angio with the volume blended reconstruction and 4D echoes have come handy for us to make out the collaterals and the supravalvular stenosis very well. Thank you very much for your kind and patient hearing. I would like to say what the mind does not know, the eyes will not see, and what the eyes do not see, the mind will not comprehend. And this is Richard Van Pra, under whom I was trained. And thank you very much for the kind and patient hearing. Thank you.
Thank you so much, madam. Very lucid, very nice to hear. You covered almost all aspects of tetralogy. It's very good to hear that. And just a question is, what is your threshold for sending for CT angios? The smaller children, the complicated ones.
Your voice is breaking.
When do you refer for CT angios? What is your threshold for sending for CT angios?
The CT angio in pulmonary atresia, especially we are not able to see the confluence, and plenty of collaterals are there and we are not able to make out, then only we send for the CT angio.
Absolutely. Thank you. Rama, I think the next speaker is Shiva Kumar, but we don't have his slides as yet.
Dr. Raghu sir, can you update whether Dr. Shiva Kumar is joining us or not? Or somebody from the Alpcar team can update us?
I sent him a message.
Yeah, I'll just check in a minute, please.
So by the time I have a question to Dr. Philip. Saji sir, you had a wonderful talk of VSD in 10-12 minutes time. So should you recommend measuring QP by QS by echocardiogram? Even though it can be done, but is it reliable or it should be done?
Yeah, I used to routinely do for the moderate to large VSDs because I want to decide about for the surgical point of view for sending for surgery. QPQS I used to measure for moderate to large VSDs.
No, but is it reliable? Like the QPQS that you obtain from echocardiogram, is it reliable in small children? Because I think a lot of echo people in adults especially understand the difficulty in measuring aortic valve area by continuous
That's true. That's true. But the
diameter, how it translates into volumes.
Yeah, that's true. QPQS alone, I won't take it up, but I compile all the parameters, including the size, the jet, and the PA size, PH, PM, mean PA, everything I should compile together, and then I will take a decision. As you said, QPQS alone may be a little bit difficult because many times the calculation may be different.
So I think one of the most important ways to assess volume overload would be the relative volume index. Like that is the Z-score for the given age. Like what is the Z-score for that LV volumes like?
Yeah, that's true. I would request Dr. Vijayalakshmi to comment on the classification of the VSDs, because a lot of which I showed is a very detailed one. So can you simplify it?
To simplify, we have to decide which are the VSTs which are suitable for surgery and which are the ones which can be taken for the device closure. So that way I classify in a practical way. So subpulmonic VST, though some people have, they never close, spontaneous closure is not there. So device closure is not suitable, they go for the surgery. So subpulmonic VST, as you showed, just below the pulmonary artery in the 12 o'clock position. Then subaortic VST or subarterial VSTs, among them the subarterial VSTs, they go for the surgery, whereas in the subaortic VST, if they are smaller ones, they go for the device closure, and if there is a muscular extension, and they go for the surgical closure. Then the mid-muscular VSTs, usually we do the device closure. However big they are, the mid-muscular are excellent for device closure. And I have closed even with the 24 millimeter VST closure. So mid-muscular VSTs are excellent. Now regarding the Swiss cheese VSTs or the apical VSTs, they are invariably multiple. Sometimes they'll have a single opening in the LV side, but multiple opening on the RV side. So these cases, we have to do the 4D echo and look from the RV side and the LV side. And the Swiss cheese VSTs can be closed with the multiple ADO2 devices. And if there is a single apical one, that can also be closed with the device, but provided this is difficult to go from the lower limb approach. So the jugular approach is better if there is an apical one. So this is the simple classification for the practical purposes for the students to do the device closure or send for the surgical.
I hear Dr. Shivakumar has logged in. Can you just check whether he is there on your screens, please?
Yeah, he is on screen.
Yeah. Can you start his talk?
Yes, Shivakumar. Yeah. Next is Dr. Shivakumar, who is going to speak on simplifying cyanotic heart disease. He's got a humongous job of simplifying, doing this in 12 minutes.
Shiva, you can share the slide.
Sure. I'm just getting it ready.
Okay.
Vanakkam, Shiva.
Thank you, madam. How are you, madam?
Fine, great.
I was enjoying your talk on the muscular VSD, and so I didn't want to come in and disturb you with my video.
Go ahead.
Can I?
Please start, Dr. Shiva. We are 3 minutes behind schedule.
Thank you. Basically, an approach to cyanotic congenital heart disease is a broader entity carrying out different types of diagnosis, which includes single ventricle to double occluded right ventricle to hypoplastic left heart, pulmonary atresia. So rather than if I show just pictures of each one of them, then it will be like a piecemeal talk. And so rather, I would like to tell how we can diagnose a congenital heart disease. Can you hear me?
Yes, sir. Yes, sir. Go ahead, sir.
Okay. So I would like to tell about some basic principles on how we approach a congenital heart disease. And so this will be called as segmental analysis, wherein we divide the heart into manageable segments. Now, once we know this segmental analysis, then it is easier to put in a diagnosis, whether it is a double outlet right ventricle or whether it's a truncus arteriosus. So I would like to rather tell that the basic three segments of the heart will be visceroatrial segment, ventricular segment, and the great arterial segment, and how it gets connected. So whenever we are talking about a complex cyanotic heart disease, most often it will not necessarily be strictly a normal situs and a normal levocardia. So we need to understand how to identify a situs solitus. On a subsified view, if you are able to see the inferior vena cava anteriorly and abdominal aorta posteriorly, IVC on the right and aorta on the left, then this is situs solitus. And exactly the opposite will be situs inversus, wherein the inferior vena cava will be in relation to the spine. So the next question will be whether the heart is on the left or not. If you do a subsified view and the heart's apex is facing towards the left, it is levocardia. If it is facing towards the right, it is dextrocardia. And if it is somewhere in the midline, then it becomes mesocardia, wherein the apex is now hitting towards the subsified probe itself. This is very commonly seen in corrected transposition. And so this will be an indirect clue that mostly the patient may have an AV discordance. If you look here carefully in this particular example, this is a mesocardic heart, which means the heart is directed towards the midline. Carefully, if you see, the tricuspid valve is on the right side and the mitral valve is on the left side. So it will look like the atria and ventricle are correctly connected. But you look at the top, this is actually the left atrium. The pulmonary veins are draining here, and this is the right atrium where the systemic veins are draining. So this is a situs inversus with corrected transposition. And so mesocardic hearts are quite often AV discordant hearts. Now, how to recognize the right and the left atrium? It's important to recognize the right and the left atrium. The right atrial appendage will be broad and triangular. This is a subsified view with the superior vena cava. This is the broad and triangular right atrial appendage. Whereas on the contrary, the left atrial appendage will be long, linear, finger-like. So this is the basic difference between the two appendages. But it is very difficult to identify only by the appendages. Some of the stronger suggestions for what is a right atrium and what is a left atrium will be, if you are able to identify the septum, the portion that is coming from the top is the septum secundum. The portion that is coming from the bottom is the septum primum. And wherever septum secundum is there, that becomes the right atrium. And wherever septum primum is there, that becomes the left atrium. And this is one foolproof method if the patient is having a relatively smaller PFO. But if there is a large ASD, we will not be able to identify this parameter. The second, another parameter that will always be useful, whenever there is a coronary sinus will always occur only in the left atrium. Coronary sinus never comes in the right atrium. So if you are seeing the body of the coronary sinus, that means this atrium is the left atrium. This is another strong point. And third strong point is inferior vena cava always enters the right atrium. We can say that there are rare conditions called total anomalous systemic venous connection, but by and large, if there is an inferior vena cava that is draining into one atria, that atria can be taken as right atria. So right superior vena cava is a variable structure. Superior vena cava can sometimes come and drain into the left atrium. So superior vena cava is not a constant structure, but inferior vena cava always drains into the right atrium. Similarly, left superior vena cava also is a variable structure. Sometimes if it is completely roofed, it will drain into the right atrium. But if it is unroofed, it may drain into the left atrium. Here it is unroofed and it is draining into the left atrium. So superior vena cava is also not a constant structure. So to differentiate between what is right and what is left, the hard findings, inferior vena cava, wherever it is drainage, it is to right atrium. Coronary sinus, wherever it is lying, that is on the floor of left atrium. And if you are able to clearly identify septum secundum and septum primum, which is possible only in restrictive ASDs, then septum secundum side is indicative of right atrium and septum primum side is indicative of left atrium. Now, the pulmonary veins may be having anomalous connections, and so pulmonary venous drainage is not a sign of whether that is the left atrium or not. Coming to between isomerism, isomerism is simply identified by one simple clinical finding, one simple echocardiographic finding. if there is an inferior vena cava interruption with an azygos that is continuing, we are not seeing a native inferior vena cava, but there is a large azygos vein that is going and draining into superior vena cava. Quite often, this condition may be a feature of left isomerism. You need to confirm that structure by putting color, and the color will show that there is a superiorly draining azygos vein turning around and coming down as the superior vena cava. Right isomerism, on the contrary, will have a patent inferior vena cava, but IVC and aorta will be on the same side of the spine. So you will find that IVC is anterior to the descending abdominal aorta, and if there is lack of lateralization, lateralization means IVC remaining on the right and abdominal aorta remaining on the left. So if there is a lack of lateralization, that is a very clear sign of right isomerism. So with this is the right isomerism. You can see this is the spine. This white color is the spine. So the aorta is also on the left side and the inferior vena cava is also on the left side. Incidentally, stomach is on the right side. So everything is abnormal. So this is a sign of right isomerism. So after this, the next will be atrioventricular connections. And atrioventricular connection, the normal connection is right atrium connected to right ventricle. But here, obviously, you are finding that it's a discordant connection. The mitral valve is on the right side, and the tricuspid valve is on the left side. Tricuspid valve has got apical attachment. Tricuspid valve is more apically displaced. Mitral valve is more basal. Mitral valve does not have any attachment towards the septum at all. So these are signs of clear-cut AV discordance. And of course, we can use some other additional criteria like 3D echocardiography. On the contrary, if suppose there is patients who are having straddling AV valves, the atrioventricular connections carefully can be analyzed. So this is a patient with a straddling inferior, like tricuspid valve. You can see that the inlet septum is cutting through about 30% of the it's separating the tricuspid valve into 30% and 70%. 70% committed to right ventricle and 30% committed to left ventricle. But still, we can clearly say that this tricuspid valve is septophilic, and so this is tricuspid, and this is mitral, and so this becomes the left ventricle and right ventricle. So identification of the two AV valves is an important finding, and that will help us in identifying which is the ventricle. The two hard findings of a left ventricle will be identification of two papillary muscles. The only ventricle which has got two well-defined papillary muscle is left ventricle. Now, sometimes these rules, like for example, identification of a moderator band, identification of a smooth surface, all will become difficult whenever one of the ventricle is hypoplastic. And so, even though we can put in simple rules like septophilic AV valve, the basally located AV valve, sometimes it will be difficult. And so this is an example of a hypoplastic right ventricle in the setting of severe cyanosis. The patient basically has hypoplastic tricuspid valve, hypoplastic right ventricle, significant cyanosis caused by shunting of the blood from the right atrium to the left atrium. No other abnormality. Right ventricle did not have any pulmonary stenosis. And so the pathology, cyanotic congenital heart disease in this patient was just due to hypoplasia of the right ventricle and a PFO shunting right ventricle. This is an example of hypoplastic left heart. Of course, this is a hypoplastic left heart syndrome, yet another congenital cyanotic congenital heart disease. So these are to be identified in the ventricular component. Now the AV connections can be, as I mentioned earlier, completely concordant or discordant. This is discordant, which I already discussed. And the third type can be, this is the first example that I showed. This is a situs inversus with AV discordance. So situs inversus, here the pulmonary veins are draining onto the right side at left atrium, and the systemic veins are draining into the left side at right atrium with AV discordance. So this is yet another complex congenital form of heart disease. And so this patient basically had isolated AV discordance, which is producing a transposition-like physiology. You can see the pulmonary veins draining in the right, and that is getting connected through the tricuspid valve to the left ventricle. And from this left ventricle, there was a discordant connection. And the double inlet ventricle, or in other words, the single ventricle, can be having either two separate AV valves. This is a double inlet ventricle. In some cases, there may not be a double inlet ventricle. It may be a common AV valve also. So like this, there may be a common AV valve, or it can be atretic AV valve. One of the AV valve can be atretic. This is a common AV valve which is favoring the right ventricle with a hypoplastic left ventricle, and this is a common AV valve larger left ventricle and a hypoplastic right ventricle. So these are the various forms of atrioventricular connection. So either it can be a common AV valve or it can be double inlet AV valve, and rarely it can be one valve being atretic. So this is a right atretic AV valve with the left AV valve being patent, or it can be left atretic AV valve with right AV valve being patent. All these may be varying forms of univentricular hearts, and all these univentricular hearts will all form parts of the complex cyanotic congenital heart diseases. Already I mentioned about straddling AV valves. This is yet another example of a straddling AV valve, large straddling AV valve almost amounting to a single ventricle causing cyanosis. And straddling can be of varying degrees. So whenever the straddling AV valve has got caudal attachments going even up to the contralateral ventricles free valve, then it's called as grade 3 straddling. So straddling can be of varying degrees. The last form of very, very unusual AV connection, we talked about double inlet ventricle, double inlet ventricle, common AV valves, and one side atresia. This is called as crisscross AV connection, wherein one of the AV valve connects to the opposite side ventricle. So here you can see. I'm
sorry to cut in, but we have to move on to the next session. The international faculty is waiting. Please forgive me for interrupting.
Okay, sir. Thank you, sir. Thank you.
If we can have the last slide or your message.
Sure. Yeah. Sure. Okay. So crisscross AV connections can be another type wherein which will be associated with supra-inferior connection. And about the ventricular-arterial connections, it can be concordant or it may be discordant. I'll just rush towards the last. So varying forms of double outlet right ventricle. So in other words, a complex cyanotic congenital heart disease, the moment it is not a conventional transposition or tetralogy, we will not be able to just look at one picture and say that this is single ventricle, this is double outlet right ventricle. It becomes building up of segments. So first we need to identify the visceroatrial segment, then the ventricular segment, and then the great arterial segment, and then see the connections between the atria and the ventricle and the great arteries. Because a complex cyanotic heart disease is basically stitching various parts of the heart together in order to come to an echocardiographic diagnosis. And so a complex cyanotic congenital heart disease echocardiography primarily will rely upon a segmental analysis. Thank you very much.
Thank you, Dr. Shiva. My sincere apologies for cutting in. Thank you, Dr. Nitin and Dr. Ramakrishna. Thank you very much for accepting our invitation to join in and conducting the session so beautifully. We'll move on to the next session.
Thank you, all speakers. Very good. Thank you so much.
Thank you. We'll move on to the next session, and I invite Dr. Krishnamraju and Dr. Soumitra Kumar. Dr. Krishnamraju is the past president of the Indian Academy of Echocardiography, and Dr. Soumitra Kumar is the current president of the Indian Academy. And they will request Dr. Roxy Senior and Dr. Sudhir Vai to join in. Over to Dr. Krishnamraju.
Good afternoon, and thanks to all delegates, faculty, and the organizers. We start moving. The first speaker will be Professor Roxy Senior. I think he's on. Is he?
Yeah, very much. Yeah.
Dr. Roxy, are you there?
Yes, I'm here.
Okay. We have Professor Roxy Senior, and he's going to speak to us on the value of exercise stress echo in mitral regurgitation. Now, Professor Roxy is very well known in our community, echocardiography committee in India, and he is a Adler Lecture Awardee, and he developed the use of contrast stress echocardiography in clinical cardiology. He also was responsible for the use of portable echo and its dissemination of its use in the community setting. He is Professor of Cardiology, Imperial College, London. Professor Roxy, please go on.
Thank you. Thank you very much. Once more, I would like to thank the organizers for inviting me virtually. I'm really missing India, by the way. It would have been so great to have been there amongst all of you. But anyway, times are different. So we'll move on. Can you see my slides?
Not yet.
Can you see the slides now?
No.
Not yet.
Okay, just 1 second. Sometimes. Okay. now?
Yes.
Yeah.
Thank you. Okay, so my talk is on utility of stress echo in mitral regurgitation. Now, before we talk about stress echo, first of all, we need to know what is a mitral valve apparatus consist of. So it consists of mitral annulus, which is contributed both by left ventricle and left atrium. We need to know that left atrium contributes greatly to the mitral annulus, and we'll come to that. The leaflets, anterior and posterior leaflets, the chordae tendineae, the papillary muscle, and the left ventricular wall. So all these can be affected by mitral. If these are affected, it can give rise to mitral regurgitation. As you can see in this slide, that mitral annulus can be affected by LV dilatation or atrial dilatation, by connective tissue disorder. Leaflets can be affected by degenerative disease like Barlow's valve, giving rise to mitral valve prolapse or cleft leaflets, rheumatic heart disease, infective endocarditis, connective tissue disorder, etc. The chordae can be affected by connective tissue disorder, infective endocarditis, rheumatic process, and myocardial ischemia. The papillary muscle can be affected by ischemia and LV remodeling, and LV wall can be affected by LV remodeling. So all these conditions can give rise to mitral regurgitation. Now, there are two types of mitral regurgitation, as we know. One is the affection of the valve primarily, and it is important to distinguish that from the second variety, which is called the secondary mitral regurgitation, because in the first variety, just treating the mitral valve will help the patient, but in the second variety, it is the underlying disease process like LV disease in terms of ischemic cardiomyopathy or dilated cardiomyopathy is the main issue, giving rise to mitral regurgitation. So in most cases, the treatment should be directed to the underlying pathology rather than to mitral regurgitation, but we'll come to the role of mitral regurgitation in these conditions. Now, why do we need to do stress echo? We need to do stress echo because mitral regurgitation is a dynamic process. It varies from one point to the other, and mostly the severity of mitral regurgitation is dependent on regurgitant orifice area and left ventricle to left atrium gradient. Now, as you can see, the regurgitant orifice area can vary depending on the LV contractility. So if it is reduced, and if the preload and afterload is increased, giving rise to LV remodeling, the mitral annulus size increases and the regurgitant orifice area increases. Similarly, if the LV to LA gradient changes, like increase in preload, increase in afterload, increase in contractility, that will give rise to change in severity of mitral regurgitation. And we know from here that the degree of mitral regurgitation actually depends on how the closing forces, which is contractility of the left ventricle during systole, and the tethering forces like the tug on the mitral leaflet by the chordae, papillary muscle, and even the left ventricle equates out. So if the closing force is more than the tethering force, there won't be any mitral regurgitation. While if the tethering force is more than the closing force, meaning the mitral valve will remain open and there'll be mitral regurgitation. And these all vary actually according to preload, afterload, and contractility, which in turns vary with day-to-day activity. So why do we need to do exercise stress echo in mitral regurgitation? And remember, when we talk about stress echo, we are referring to physiological stress, that an exercise test, because that actually uncovers what the patient does in terms of his day-to-day activity. So the reason for doing exercise echo is to, first of all, uncover the symptoms. And I'll come to that, the reasons for doing that. to assess functional capacity, to assess the mechanism of MR, because the mechanism of MR will decide whether the type of intervention the patient might need. And to a large extent, exercise echo can uncover the mechanism of MR if it is not clear during rest echo. And of course, the severity of MR, and finally, what the left ventricle is doing, what the right ventricle is doing, so contractile reserve of these two ventricles. So that's the importance of doing exercise echo in MR. Now, so these are the conditions, very common conditions where exercise echo helps in making a decision on the patient. Now, if we talk about primary mitral regurgitation, it's mainly in conditions where there's a discordance between the symptoms and the degree of mitral regurgitation. So let's look at the first variety, where the patient has got a lot of symptoms, but on rest echo, there's only mild or at most moderate mitral regurgitation. So there we want to uncover the degree of mitral regurgitation during stress, because that's where the symptoms appear, and what happens to the mitral regurgitation during the symptoms. And we do exercise tests, and mainly bicycle tests, because we need to look at the valve, the left ventricle, the right ventricle, the pulmonary artery pressure, the degree of MR, the filling pressures at each stage of exercise, especially at the low level of exercise, because that is most important to uncover the importance of the severity of mitral regurgitation. Not so much as peak exercise, because when somebody exercises quite a lot, on its, you can say the patient has exercised very well, and even if the mitral regurgitation gets a bit severe as a result of that, it may not equate to what the patient actually does on day-to-day activity, and it may not be that prognostic. Similarly, the rise in pulmonary artery pressure can be, exponential. During peak exercise, in athletes, for example, they can exercise for 15 minutes, and the pulmonary artery pressure can go up to about 60 millimeters of mercury. So it's a low level of exercise which is important to uncover. So in this particular scenario, where you need to know what happens to the mitral valve, you quantify the mitral valve, and you quantify the left ventricular function, and then decide whether the MR actually has increased or the left ventricular function has decreased as a result of increase in MR, which is giving rise to symptoms. Now, the other variety is where the patient has got asymptomatic severe mitral regurgitation. Now, we know from this guidelines that if the patient has symptoms, then of course the patient gets an intervention done. Now, if the patient is asymptomatic, and if the valve, if the LV function is reduced or the end systolic diameter is high, there also the patient undergoes intervention. But we are talking about a patient with a normal LV function in terms of more than 60% ejection fraction, end systolic diameter less than 4 centimeter. Now here you assess whether the patient has got AF or whether the patient's got resting pulmonary arterial hypertension. Now, if they do, then these patients should undergo mitral valve intervention. Now, mitral valve repair is the first intervention of choice because it is prognostically a better intervention. But if not, then the patient can also proceed to mitral valve replacement. Now, if these patients do not have AF or pulmonary arterial hypertension, then if the mitral valve repair is likely, then this patient should undergo mitral valve repair. Now, what happens if the patient is not suitable for mitral valve repair in absence of, AF and pulmonary arterial hypertension? Remember, doing mitral valve replacement does carry a higher risk, and the prognosis is not as good as mitral valve repair. Now, that's where we need to decide whether this patient has a prognostically significant mitral regurgitation, meaning is this patient going to get into trouble very soon, and therefore we should go ahead and get even the mitral valve replacement done. And for that, we do stress echo, exercise bicycle again. And here, because this MR is already severe, We look at surrogates of prognostic factors like pulmonary artery systolic pressure, left ventricular ejection fraction at peak stress, and the degree of increase in mitral regurgitation also is important because that also impacts on pulmonary artery systolic pressure. And finally, we come to a functional mitral regurgitation where the underlying problem is the left ventricle. Now here, the usefulness of stress echo is to uncover symptoms because patients can go into severe acute onset heart failure with LV dysfunction. The question is whether mitral regurgitation is responsible, and there you can exercise the patient to see whether the mitral valve regurgitation becomes significant, accounting for the symptoms, and then we intervene accordingly. Now, so what are the protocol that we use? As I've said, the protocol is bicycle exercise. We start off with a rest assessment, then assessment at low levels of exercise at about 50 watts, where the heart rate is about 100 to 120. And that's where most of the abnormalities should be detected. So now I will show you some examples. So let's talk about this patient who is symptomatic, but has got only mild mitral regurgitation and because of mitral valve prolapse. And this is a patient, you can see the mitral valve is very abnormal. Both are billowing and prolapsing, both leaflets. LV ejection fraction is normal. And this is the MR at rest. You can see there's a squirt in mid to late systole. And so you quantify the mitral regurgitation. As you can see, the effective orifice area here is 0.29 centimeters square with a regurgitated volume of 37. So it's clearly mild to moderate mitral regurgitation, but the patient is very symptomatic. So now the basal pulmonary artery pressure is normal. As you can see, it's only 3 meters per second. Now this is at exercise. And you can see with exercise, the mitral regurgitation has changed somewhat, but quantification is important. You measure the PISA and you find that the EROA remains 0.29 despite the fact that you see a bit more color in the left ventricle. And the MR volume remains about 37, and the pulmonary artery pressure did not change. So this is looking at the dynamics actually during peak exercise. It's similar, 0.2, 7.29, and the MR volume hasn't increased. It remains mid to late systolic, and the pulmonary artery pressure did not rise very much. So in this particular scenario, mitral regurgitation is not responsible for the patient's symptoms. Indeed, the cardiac hemodynamics were not responsible for the patient's symptoms. So we have to look for other causes for that. Now, of course, now this is, we look at wall motion, as you can see. So this is the same patient. So we looked at the LV at stress and rest, and you can see the LV ejection fraction is improved significantly. And as I've said, the cardiac hemodynamics wasn't responsible for the patient's symptoms. And these are the results, which we quote. The EROA hasn't changed. Pulmonary artery pressure didn't rise significantly. LV ejection fraction has just changed, has improved, in fact, so suggesting there's contractile reserve, and there's no evidence of myocardial ischemia. So this is another patient with mitral valve prolapse. Again, you can see similarly, moderate MR, significant symptoms. Now this patient is also exercised, and you can see the mitral regurgitation again appears a bit more. Now on measurements, you can see now the EROA has increased points from 0.34 to 0.44, and the regurgitation volume has increased to 71. But what is very important here for you to see is the mitral regurgitation remains mid to late systolic. And when we measured, the sonographer who measured this actually overestimated the regurgitation volume, because this particular sonographer took it from the beginning of QRS to the end of the regurgitation jet, but actually the regurgitation is mid to late systolic, and that is the regurgitation volume, which is very similar to what it is at rest. So we have to be careful that with mitral valve prolapse, if remains mid to late systolic, though the color flow appears to be much prominent, and the EROA, though it increases significantly, it is just at that time point that we are measuring. We are not talking about a pan-systolic EROA. So here the regurgitant volume is a more exact measure of the severity of MR. And in this case, the regurgitant volume remains low, because if you measure from mid to late systolic, it's half of that VTI, and that comes down to about 40 ml. So here, we conclusively said the MR hasn't deteriorated. In fact, the pulmonary artery pressure did not exceed 60 in this particular place. So we continued looking for other causes of mitral regurgitation. Now, this is another patient, a 40-year-old man who's got previous ischemic heart disease and has got PCI to LAD and LCX and has got atypical chest pain. So the first thing we do is to see whether the chest pain is due to myocardial ischemia. And because the patient has got LV dysfunction, he underwent dovitamin stress echo. But before that, just looking at the dynamics, so you can see the LV function is markedly reduced, the filling pressures are markedly raised, and there is mild mitral regurgitation, and you can see the anterior leaflet and the posterior leaflet are coapting within the left ventricle. So this patient has got mild functional mitral regurgitation at rest. So first of all, we need to decide what is this chest pain. So we did the dobutamine, and this is at rest, low dose, high dose, and what you can see is the whole of the apex is infarcted. There's no change throughout, but what you see in the inferior septum, you can see it improved at low dose, and then it deteriorated at increased dose. And similarly, if you look at the anterolateral wall, it improved here and then deteriorated, meaning there is a lot of ischemia going on. And this is also shown in the two-chamber view here. You can see that the inferior wall has improved, but then deteriorated again. And the anterior wall is also coming down at peak stress. And in the three-chamber view, essentially nothing changed very much. So this patient had infarcted apex, which is about 7 segments, and there is viability and inducible ischemia in about 8 segments. Now, this patient had a coronary angiography, showed